Vincent Liu from Kaiser Permanente, Oakland, California, who's going to be speaking about how the future is bright for AI.
Great, thank you very much to the chairs for the opportunity to speak. Let's see, I just wanted to start off by saying that we are on the cusp or in the fourth industrial revolution. So if the first industrial revolution was steam power, the second electricity, the third driven by electronics and information technology, here Klaus Schwab from the World Economic Forum says the fourth is blurring the line between physical, digital, and biologic spheres with unprecedented processing power and unlimited access to knowledge. And that innovation is going to be driven by multiple breakthroughs in AI, robotics, Internet of Things, autonomous vehicles, 3D printing, nanobiotechnology, material science, energy storage, and quantum computing. And over the past 5 or 10 years, all of these areas have entered into our vocabulary as things that we are using or at least thinking about. But as our chair said, I like to think about AI as augmented intelligence, at least when it comes to us as clinicians, because augmented intelligence places patients, clinicians, and communities rather than the algorithms at its center. And since what we do is fundamentally the art of caring for patients, it's essential that we leverage these technologies with people at the middle. And that's particularly important in the ICU because burnout has long been a problem. This is a report from the U.S. National Academies of Science, Engineering, and Medicine. This was actually before COVID. They recognized that, you know, what I heard in medical school was that doctors and dentists suffer from the 4 Ds: drugs, drinking, divorce, and depression. And Michael says there's another one. But anyhow, and that's only been further exacerbated by everything that we've gone through, and our colleagues, obviously, like nurses, have gone through during the pandemic. So what is the opportunity for us to leverage this exciting new technology on the cusp or inside of this fourth industrial revolution, and how do we think about it? And so I'm going to run quickly just through some high-level thoughts about where I see the future, and I frame them into kind of 3 phases. And each of these phases is really around a role. You know, if we have this technology fully developed, baked into the things that we use, what could we see it doing, and what's the time frame that we would see it? So there's phase 1, which is things which are currently available. I may mention some. You may feel like I already do that. But I think there's a maturing over this next 5 years. Phase 2 are methods and algorithms that are available, but are going to take some time, you know, to really get disseminated. And then phase 3, I'm not actually going to go into depth about because I don't want to run long in my talk, but we'll briefly touch on them. Okay, so phase 1 is like a reference librarian. So ChatGPT has been the topic of some conversations, and I just want to take us through an experiment. Who knows what HLH is? Just raise your hand. Okay, so not as many as I would have thought, but you know, this is an engine that you can ask questions like HLH is hemophagocytic lymphohistiocytosis. It's marked by essentially the body's overwhelming inflammation and a cytokine storm. Among those who know what HLH is, how would you diagnose it? And you know, this type of functionality as a reference librarian is kind of immediately at our fingertips. So, you know, a patient with cytopenias, with fever, with hepatosplenomegaly, et cetera, you can rapidly call up these kinds of things, right? And we know that we can do this through search engines or other kind of medical libraries, but the ability for technology to, within seconds, synthesize an entire field and at least give us some understanding. And in some cases, we're already experts in this domain, but there's sub-areas of the domain that we don't really understand. And what about things that are in the field of medicine, but that are not directly related to us, like briefly describe the stages of macular degeneration? Or even outside of our domain, in one paragraph, describe the implications of the Magna Carta to law. And then finally, explain why butterflies don't fly in a straight line. So not only does it have kind of a depth of knowledge within a certain domain that we may feel experts in, but it actually exhibits that breadth across a very wide field. And so I think this is a technology available to us today, and it's something that can really help to synthesize knowledge. I'll go on. Medical scribes, I think AI has the opportunity to replace medical scribes. So this is a study from the US that showed that for every hour of direct clinical FaceTime with patients, physicians were spending almost 2 hours on EHR and desk work. And then for among those physicians who worked after hours, they would spend an additional 1 to 2 hours on EHR and desk work. And that may be because of the fact that in the US, we're over documenting. So this is a distribution of the number of characters in an EHR note, where the US are the light bars and the rest of the world is the dark bars. So we are enslaved somewhat to this documentation, but I think easily there's a capability here for AI to not only to be a transcriber, and that functionality is available today, but actually to be a synthesizer, right? And that's the value of medical scribe. They don't just simply write down every word that's been said, but they actually spend time to kind of streamline it, make it sensible, make it into understandable medical prose. Okay, let's keep going. A patient liaison. So this is just an example, back to HLH. Explain HLH to a 10-year-old in 2 or 3 sentences. So HLH is a rare condition where the body's immune system becomes too active and starts attacking its own organs. This can make a person very sick, and they may need special treatments to help them feel better. I think that's a very passable example of what we might say to a patient. You could even say, make it into a limerick, and we saw an example of this yesterday. HLH is a condition so rare that causes a great health scare. The immune system's attack makes the body go off track, but treatment can help repair. So it's able to rip off these things extremely rapidly. What if you wanted to say, make a child's drawing of an immune cell attacking its own body? Or now make it a limerick in French. So I'm not going to read that off because I will embarrass myself. But you can see how, as a patient liaison, this kind of technology can help us communicate patients rapidly, even across different types of barriers, whether that be age, whether that be health literacy, whether that be language, or whether that be the domains through which they understand the care we're trying to provide. We've seen lots of examples of AI being used as a risk profiler, whether it's in an example is our work in an early warning score in the hospital. Suchi Saria's work that was published recently in Nature Medicine about predictive models in sepsis, or Azra Behorik's group's work about neural networks, for example, in postoperative complications. And we're going to see more and more of these. This is work that I'll talk about a little bit later, but that shows all of the models over time here from 1990 to 2020, which have been developed and use machine learning for in-hospital mortality performance. And you can see over time, of course, there's been more and more. And perhaps, whether or not we've seen improvements in performance is another question. And then finally, I think in this first phase, an operations optimizer. So this is an example of a very simplistic approach to how Uber matches passengers and cars. So let's say you have passenger A and passenger B, you have car A and car B. The simplest matching approach would simply be to bring the closest car to the person. The result would be that the wait here would be 2 minutes and the wait here would be 9 minutes. Better would be to examine all of the potential times across the entire population and then optimize for that. Right, so if you send, looking at traffic patterns, if you actually send car A to passenger B, that increases their time from 2 to 4 minutes. But if you do that in the other car B to passenger A, their time drops from 9 minutes to 4 minutes. And it's a way of globally optimizing a set of processes so that you can improve the overall performance. And we have examples of things like this already in medicine. For example, the kidney transplant domino process in which, any donor and recipient, any willing donor with a recipient can't be matched directly because of whatever immunologic differences. And yet what can happen is that by creating a matching algorithm, you can essentially have a very long chain of donations that go to other recipients. And this was actually 11 years ago in the New York Times about one of the longest chains in the US, where there was 30 kidney donations in series based on this first actually non-directed donor. So a really generous person says, I'm going to donate, and what that allowed for is this optimization of the entire process. And we could imagine this technology like through a workflow optimizer. We have a list of tasks. They're a balance between risks and opportunities. We begin completing some tasks, and we see that the list gets reorganized, right, to optimize the patient's benefit for all of our patients in the ICU rather than focusing in on any individual patient. Okay, so those technologies are largely available to us today. I don't think that's any surprise, and I think we're going to see them become disseminated. What about over the next period of time? Well, I think there's a huge potential in the ICU for ambient monitoring. We are going to hear about some of that today with lots of detailed physiologic monitoring. But we know today that if you take a EKG in normal sinus rhythm, that using AI, you can accurately identify patients who are going to go on to have AFib. Okay, and so, and if you take multiple EKGs, you're going to do even better. We know today that in stage 1 lung cancer, that if you have a computer vision application that examines the pathologic slide, it can actually pick up features that help you stratify patients who are going to have longer survival and shorter survival. This work is multiple years old now. We know even that this was published in Nature, that if you have a live echocardiogram, that AI can detect beat-to-beat differences in the characteristics of that image and give you something like an automated calculation of stroke volume, which is at least as good as a clinician, if not better. We know that if you put a sensor into like a camera-like sensor into a room, it can detect things like movement, it can detect activation, mobilization, and colleagues at Stanford are building an atlas that will actually examine through video all of the actions that are taking place so that they'll be automatically understood. So I think that's where we're headed, is a future in which we will no longer be using tools like CAM ICU to characterize or quantify delirium. We will be using facial expressions, signs of pain, signs of kind of disordered motion to help us understand and then quantify what cognitive stage a patient is in or how they are in delirium. And the environment will be filled with these kind of sensors, whether they're little stickers, bio-stickers that are attached to patients, whether they're cameras or other sensors. We certainly are going to see this as the frontier. Okay. What about AI as a risk manager? So I don't know if you have this, if this happens to you, sometimes you're shopping for something and then magically an ad appears, right, shortly thereafter, and you're like, that's crazy. How did it know that I was going to look for that? Or perhaps you're on a website, and as you scroll down, a chat function comes up. And so it's on-demand and personalized, insights that help you kind of accomplish a goal. And I think we're going to see this because we know that using machine learning techniques, we can unpack the depths of all of the actions, labs, orders, and meds that we give a patient while they're in the hospital. We know this, for example, this is a study from my group where we looked at search terms in the EHR. So if a physician searched for one term, what was the next term they searched for? And then we built those into a giant graph network to look at how those, this is all cardiovascular, this is mental health related, this is depression, and this is respiratory diseases. But we can use all of these data together to kind of create a plot like this and do anomaly detection. So that if all of your patterns are working together to point towards one thing, yet you haven't yet clinched the diagnosis, a pop-up would say, would you like to talk about HLH? Do you want a second opinion? Do you need a second, do we need to discuss this? And I think that's more than a risk profiler, because a risk profiler is very narrow. A risk manager seeks to do this across all of kind of the actions that you're taking. Okay, a treatment recommender. So we know that AI has outperformed humans in chess now for almost 20 years. We know that AI can beat humans in Go, which is one of the most complex board games. That's at least 5 years old. In fact, we know that AI can beat StarCraft 2, which is a very, very complex video game. And in fact, they use this process of reinforcement learning, where the machines are improved by building together an entire set of video AI game players, and they compete against each other. And it's essentially a self-learning system. And so we're seeing early applications in that. So for example, the AI clinician, this is Matthew Komorowski, Tony Gordon, and others, where they are essentially taking that video game-like approach of reinforcement learning, putting it into AI and understanding, what are the optimal states during which we should give fluids versus during which we should give vasopressor. So the future will include some of that. Okay, two more here. So patient companions, we know the devastating effect of social isolation among older people, both as in their ambulatory scenario, but also within the ICU. And of course, COVID highlighted that for us. And so we are going to see, not just a patient liaison, but a full patient companion. So, we're very familiar now with applications of telemedicine, and I think we're absolutely going to see that flow out into full patient companions. And that leads to my kind of final one for stage 2, which is robotic aids. So, of course, these robots already exist. I forget the name of this one, but already, journals are asking, will a robot be your next best friend? There's robots that can help with nursing tasks. There are robots that help with pharmacy dispensing, drug delivery. There are robots that can help us mobilize patients, right? Robotic exoskeletons that can help us, instead of taking an entire team to mobilize a ventilator patient, perhaps just one person. There are even robots now that are doing endovascular procedures. So using a series of magnets, they're able to drive these catheters forward and release thromboses. And then robots which can do robotic ultrasound. So the arm is able to move, and then the AI can interpret the image. And so we're definitely going to see a lot of those things at the frontier. Okay, so I haven't touched on phase 3, but I think the key here is that we're going to see these technologies even continue to expand more. The key is that in phase 3, AI is not just a tool, it's a colleague. And that may seem crazy, but maybe this is the example from Iron Man, where this technology is crossing the digital, physical, and biologic spheres, really to become a colleague in the way we provide care to the patients. So I think for AI in the ICU, the future is bright. It is so bright, it's nearly blinding. And then, so that'll be, I think, a lead into our next speaker. Thank you.
Well, thank you, Vincent. Like I said, we can take a couple questions, and we certainly want to make this an active conference. So please speak up. Don't let them off the hook.
There's a question over there. Can we have the mic here?
Can you just raise it? Thank you.
Thank you for your presentation. You mentioned about the reference library. You gave ChatGPT as an example, but what's the advantage compared with current medical consultant software like UpToDate and BMG best practice that the medical student often use? Because these data are quite how to specialize peer reviewed, and what if the ChatGPT data is wrong or something? So how can you solve that, and how can you make the ChatGPT result is better than the medical consultant software? Thank you.
Yeah, thank you. Great question. So, I mean, I think that's definitely a concern, and I would say there's two areas. The first is that things like UpToDate are incredibly useful, expert curated, but they require humans to go through and edit, right? And so you can imagine if you're the editor of a specific HLH topic, it takes a huge amount of time and resources to actually do all that. The AI applications actually self-learn. Now, there's the potential, I think we'll get to that, about where that's dangerous. But I think there is a huge potential, the self-learning capabilities. And then the second I would say is do we have access to the UpToDate for law or politics or a field outside of ours? And I don't think so, right? Because we're not customers of that, and we maybe don't even know where to start. I think part of it is that tools like this show an extremely wide breadth of expertise, or at least the beginnings of some expertise. And so it's not the final answer for all of our understanding of how we practice, but it's certainly something that I think many folks will be using to begin a synthesis of knowledge that they can then dive deeper into.
Thank you. I think for the sake of time, we have to proceed. So it's now my pleasure to introduce the next speaker, Jan De Waele, who is a direct colleague of me in Ghent University Hospital in Belgium. And he will talk about the dark side of artificial intelligence.
Thank you, Lisbeth. Do you have an hour or two? Or no, I only have 15 minutes, of course. And I very much like the introduction that Dr. Liu made about how it can be blinding as much as fascinating and, of course, interesting. And of course, there's a future, certainly, for artificial intelligence in intensive care. But I think we need to know how it works, and we need to know the potential dangers as well. These are my disclosures, none of them relevant. I do have to add that we are working with colleagues at Ghent University on technology to improve infection management in the ICU. And it's clear that we expect a lot. Yesterday, the chairman of this conference explained how artificial intelligence will change critical care medicine, and I absolutely believe so. But again, I think as clinicians, if we're at the bedside of patients, we need to know how it works and what the potential dangers are. Now, artificial intelligence, and I won't go into detail, but it's a subset of computer sciences, and whenever you want a machine to behave like a human, this is already artificial intelligence. What Dr. Liu talked about, of course, was much more advanced, and this is really something that is very promising, and I absolutely agree. Now, why do we like artificial intelligence so much? Probably because we feel that in many areas, many diseases, well, we regularly see our limitations of understanding of complex processes. And that's when we hope that a technology that is much more efficient at computing things will take over and will actually do better than humans do. But this is actually the question, is this the case? And I always ask the question, if technology needs like more than thousands of pictures of a cat to analyze before it actually can recognize one, I always wonder how smart such a system can be. So definitely there is a dark side, and I will touch upon a few very important things that I think everybody, not only those who are into the research projects, should be aware of. The dark side of artificial intelligence. Now, the previous speaker used ChatGPT as an example how wonderful and how smart these systems are. And of course, it's fascinating, and I don't know if you've tried it, but you should, and you throw a simple question at it, and you get a fantastic text back that really looks well, that sounds well, but is it really always that correct? Now, if you ask ChatGPT, are you reliable? Well, I have to say, there is some self-knowledge here. Just saying that I'm a machine and my responses are generated algorithmically. So sometimes I may be wrong, and this is indeed the case. Essentially what it does, it combines words that are statistically related and then brings it together in a text that reads well and that sounds well. Now, just as an experiment, I had to write a short biosketch for this conference. So I asked ChatGPT, just write a biosketch, 200 words. I mean, my profile is on social media, the university has my CV online. And the fascinating thing, it got a lot of things wrong. It got my date of birth wrong. It got it wrong when and where I had my training in critical care medicine. It claimed I had affiliations with the University of Florida, that I had received rewards from societies that I didn't know of. So once you go into an area that you are very knowledgeable about, then you may find surprising things. And of course, the HLH example is very nice. We don't know it. It looks good. It sounds good. So it must be true. And this is not always the case. So I really challenge you to try this yourself at home. Just a short overview of how we've been using this technology in critical care medicine so far. This is a very nice systematic review. It's already 2 years old, but still, I think it points to a number of limitations of our current research projects. So in the systematic review, these are the different aims of the studies. Most of the studies actually focus on predicting complications, predicting mortality, classifying subpopulations, but the staggering finding is that the majority of these studies have been done retrospectively on databases that exist. Very few have actually used external data to validate it, and almost none of them actually tested these models in clinical practice. And a lot of bias in these different studies, both in the participant and in the analysis. So also there, from a methodological point of view, there are some issues with what we've done so far. This figure nicely gives you an overview of the levels of readiness. So going from a model development up to clinical outcome evaluation. And the size of the circles actually are the number of articles that have been published throughout the past 30 years. And you can see the majority of these studies aimed at developing, prototyping a model, but very few actually validated it. And real-time testing, almost none of these models have been tested real-time. So that's quite a worrying thing to me. This small piece actually very nicely shows you, like, artificial intelligence is not just something we should trust immediately, and that's more or less the attitude a lot of us have. It's much smarter than we are, so therefore we must trust it. There's a risk of, garbage in, garbage out. That's what we know in conventional research. Probably for artificial intelligence, it's more like the omics stuff, where if you get garbage in, it really becomes problematic. Whether you can rely the results. Now, a big problem, I think, is that our biases are actually transferred, are ingrained in these models. We only collect data on patients for certain diseases, patients who are well educated, who have maybe access to healthcare, and we automatically assume that this also applies to patient populations that are not covered. And there's many examples, not only in medicine, but in insurance, in crime data, where this is an important problem. And another thing, we always use the labels that we as doctors assign. The delirium, sepsis, ARDS, well, of course we can develop models, but we should acknowledge that maybe the label that we assign, based on our current knowledge, is not maybe the correct one. And therefore the whole concept actually could be questioned. Data shift, I think, is an important problem. This has been shown already in a lot of studies. When a development cohort doesn't really match the cohort of patients where this new algorithm is applied to. And there's many reasons for that. It could be that the population changed, that the season changed, and that maybe a new intervention, a new drug was used in this population, or patient behavior changes. And then a model may not perform as good as in the initial population in which it was developed on. And I think it's so crucial that we are aware of this, that we should not blindly believe that a model that has been developed in Italy can automatically be applied in California or in Mumbai. One such example comes from the EPIC sepsis model, which is built into the EPIC PDMS. It was developed and had roughly an AUC of 0.8. When it was validated externally in another hospital, actually, the performance was much less, and only 0.63 AUC. So just the same model, different population, different outcome. And the question is, can you just use this? And I would say, no, of course you can't. But it's not only that. Often, most often, we compare artificial intelligence performance to doctors' performance. And this is an example, it's a nice one, where actually artificial intelligence was used to analyze X-rays from knees from patients and then used to predict whether they would need a knee replacement later on. It was developed well, but when symptoms, patients' experience were added, in fact, the model improved, but also more uneducated people actually got access to knee replacements. So again, an example how biases are ingrained based on the data you have, the patients you have data of, and how it translates to a model that performs not optimally. There's always this discussion between white box and black boxes being, you don't know, you know the input and you know the output, but you have no idea how it's been developed. I think in medicine it's pretty clear that we don't want black boxes and we should have explainability. And this is also now, I think, in the legal framework that is developed for artificial intelligence in medicine at large. Algorithm quality, the potential impact of a bad algorithm is huge. If you have like a doctor who's not really good at treating patients or a surgeon, well, the damage, so to speak, is pretty limited. It's only the patient that he or she treats. When an algorithm is used on thousands, 100,000, millions of patients, then the damage actually is much bigger, and therefore the impact could be huge if your algorithm is not appropriate. There's a lot of technological and even legal issues. There's data security, also the interaction, the dashboarding, how we will transfer all of this information to the physician, what will we prioritize. It's very critical. There's a huge risk of information overload, alert fatigue in these systems, and all of this, these are not obstacles and reasons we should stop doing things, but it's something to consider when we translate this to a clinical practice. So I think we need to have a really critical look at it. As critical care clinicians, we should be aware of it. That's the absolutely first step. Path to implementing, step by step, of course. Data quality and availability is very important. Development of the models, of course, also very important. Questions should be clinically relevant, and the model performance should be tested. But also this final phase, implementing, deploying artificial intelligence, of course, is very important. Implementation science will be critical, I think, for the success of artificial intelligence in critical care. So let's go back to the patient, to the ICU. How will we be using it? And even more so, what are our attitudes? There's not a lot of information, but this comes from a single center study from the Netherlands. What the attitude of ICU healthcare workers towards artificial intelligence is. And just keep in mind what I just told you. But look at these data. It's 50% nurses, 50% doctors from an academic center in the Netherlands. So everybody is very eager to use artificial intelligence when it is technologically deemed ready, however that is defined. People really believe that it can make work easier, and I absolutely support that. Also that AI will outperform humans. But then it's really, when you look at the risks, the majority of the respondents don't think there's any risk involved in using artificial intelligence in the ICU. Only 6% actually disagrees on that. And artificial intelligence can be used reliably in ICU decision-making. Again, a lot of trust. We put a lot of trust in these systems, and I think we need to be much more critical. So it's going to be an exciting next 10, 20 years. I'm absolutely sure we will learn a lot. We will see new developments in many, many different ways. But I do think there are some issues. Absolutely, it's a hot topic, and we do a lot of research. And it is part of this path to individualized medicine. Absolutely, very promising, but many challenges. The biases, the risk of bias, I think it's huge. Inequity, the ethical aspects involved are very important and should be considered. I didn't even touch on who owns the data, whether it's the patient who owns the data, a company that owns the data, et cetera, But overall, I hope that you are convinced that we need to have a critical stance, and for that, I hope the force will be with you. Thank you very much.
Thank you very much. Are there questions from within the audience? We see a question over there.
Hello, thank you for a very nice lecture. My question is regarding transparency and accountability. As in deep learning, you actually don't really know exactly what was the process. So the transparency of the decision making is not there. And my question is in regarding to how do you know that in the future algorithm like that would not be influenced or even hijacked, and you won't have any idea that since you don't have the transparency of the process, you don't have any idea how it is influenced, now it is making its decision making. And of course, the accountability. If he makes wrong decisions, who is accountable?
Very good points. I absolutely agree. Now, when it comes to transparency, I think for me it's clear that we cannot have black boxes and everything should be transparent. And there's nice ways now how to visualize actually the different elements that contribute to a certain decision. So I think that's more or less being taken care of, and I think again that as a critical care profession, we should be very strict on that and not allow black boxes to be used. And again, I think in Europe it's impossible. It will be impossible to do that. The legislation is quite strict. And accountability, of course, well, that's a whole other debate, but also there important issues to be considered.
Other questions? Yeah, over there. Can we have the mic in front? Thank you.
So this is a question for both speakers. With the development of larger, more complex algorithms that cross fields, or the more generative AI models that require billions of features in order to make, the question of scale and proprietary nature and the challenges in medicine as we try to scale up to be more robust versus the costs that it involves in having that type of breadth.
I mean, I can try, but so normally I'm giving this talk about the dangers, but I wanted to give a really bright opportunity. But I think one risk, and maybe this gets to this point, is who owns the machinery that's capable of executing these AI. And increasingly, with things like large language models like ChatGPT, and Google just released their own, user interface for their chat, I think today or yesterday. But increasingly, only companies that have the computing power to do it own it, and that's a danger for us because not only do we have to be aware of everything that you spoke of, but also whether we have the ability to exert control in that process. And so I think that is a major concern, something we should be aware of.
Yeah. I also think that legislation on this typically lags behind, or has the reflects to be very restrictive, in order to prevent any misuse, also actually preventing any use of data.
Well, I think we'll go on to the next session, or maybe some time later for the questions if the speakers can stay on to the end. Our next speaker is Michelle Gong from Montefiore, New York, who's going to speak to us about how intelligent is artificial intelligence.
So thank you very much for this invitation to talk to you today. So, we've heard about the bright and the dark side of artificial intelligence, and I guess I'm here to kind of bring us down to reality. And no relevant conflict of interest to this particular talk. Because with any kind of disruptive technology, and indeed actually with any new interventions or treatment that we have in medicine, what it really comes down to is whether or not it improves patient outcome or improves some efficiency or something, right? They're tools. And in my mind, actually, the way to move towards a smart AI that can improve outcomes really has two arms to it. What I call the efferent arm which is the arm that takes the data from the patient, process it by some AI to give some useful information that we then direct to the providers. And then there's the afferent arm, which is what happened after you alerted or notified or outputted that context to the providers. What happens at that point? What actions is taken, and whether or not it will change the outcomes of the patient. So let's talk a bit about the efferent arm first, right? Getting to the accurate AI. And we've talked about this a little bit in different places. Is the event being modeled right? Is the model validated, and will it be validated in institutions like yours so that you know it will work? And is the prediction timely? Is it going to help if it actually occurs too late? So, is the event being modeled right? You know, Jan was talking about garbage in, garbage out in some ways. And here's where actually all the AIs that we've been discussed, a lot of them are looking for similar things, but not exactly the same, right? Some are looking at mortality. However, predicting expected mortality is not necessarily going to improve outcomes. So which type of mortality you're looking for? Some will predict for ICU admission. But again, ICU admission may be highly variable, right? Depending on how many beds you have, your institution, your provider, and not necessarily an indicator of high risk of mortality, especially if you have a lot of ICU beds and you can admit patients in for monitoring. And then there's cardiac arrest. Well, cardiac arrest, sounds nice, except that when you look at the proportion of cardiac arrests in the hospital, only a fraction of them are what's considered preventable cardiac arrest. And what about sepsis? This is another one that a lot of models have come out looking at AI and sepsis. And this is another issue of like garbage in, garbage out, because I don't know actually how to define sepsis. We often use Q-SOFA because actually Q-SOFA was good at discriminating mortality in those patients with infection. That's actually how it got published and validated. The problem is Q-SOFA is not great at discriminating against mortality. It's actually worse than early warning scores like NEWS and MEWS. And actually, how can I ask AI to do something when we as clinicians not necessarily even agree on this issue of sepsis? So when you look at actually have physicians reevaluate the charts of a patient to determine whether or not the patient has sepsis or not, it turns out that they don't always agree. They're more likely to agree if they get to look at the entire course of the hospitalization, right, including whether a patient died or not. But if you ask them at the beginning and then ask them again after discharge, up to a quarter to almost a third of those physicians will change their mind about whether or not the patient had sepsis. And it varied depending on the type of sepsis. There's more agreement when it's non-respiratory infection, but actually physicians don't agree very much if it's a respiratory infection. The kappa is actually poor at 0.24. So we're asking AI to try to identify something that we may not necessarily agree with. Jan talked about actually how the bulk of the AI that has been published varied greatly in terms of its performance. And there's also a lot of variation in terms of the number of data that's inputted, the type of data that's inputted, and in the clinical setting in which it's validated. So like sepsis, for example, it's been validated in the ED setting only, in the ICU setting only, in the hospital settings in other cases. And most, 96% of these models, as was indicated before, was all validated retrospectively. And very few of them were validated externally. So their generalizability is unclear. And universally among all these kind of AI scores is that performance worsen the earlier you want to predict for an event. And that's oftentimes a balancing act. If you want things early, you're going to end up dealing with lesser amount of discrimination and a lower positive predictive value. So let's move on then to the afferent arm. How is the AI going to change the clinical course to improve outcome? And that looks at actually what happens after the model outputs. Who is it going to output the results to? When and where? And will the alert elicit the desired response? And what is the desired response? What do you want the physicians to do, or the nurse, or whatever provider is alerted to? And ultimately, actually, will it change the outcome or improve efficiency? And we can't just necessarily assume that once you know about it, you will do something about it. Because when they've looked at actually perceptions of a utility of an early warning score for sepsis in this particular study, it turns out that only a minority of physicians, somewhere around 15, 20%, thought that it was helpful. And nurses thought it would be helpful a little bit more. Now, why is that? Well, at least a third of those physicians thought that the alert was already telling them something they already knew. So it wasn't going to change anything they do. And when you ask whether or not it actually helped the patient, did they think it actually improved outcomes, a minority of physicians, and still only about like 30% or so of the nurses, thought that it improved care. And they either didn't change the management or the expectations of the physicians or the nurse with regards to what they think was going to happen with the patient anyway. And there are a lot of reasons for these kind of inadequate response, right? The black box that we talked about. People may not trust something they don't necessarily understand. And there's this double-edged sword of being too early or being too late. If the alert is too early, when the patient is not very sick, they may not seem sick enough at the time of alert, then like, what do? They're not sick enough to go to the ICU, but what are you supposed to do to prevent that? And then when it's too late, as we can see, then the clinicians generally disregard that, but all subsequent alerts for other patients as well. And that comes a little bit to this high false positive rate, which we'll talk about in a bit. So like anything else in medicine, right, we have new technology or new therapy. What is really needed to understand whether it improves outcomes or efficiency is robust, multi-center clinical trials. And we're kind of getting there, okay? There's been a lot more actually that's been published that has been shown to see actually do these things actually affect outcome. So this is one that is looking at e-cards, that's looking at an early warning score on in-hospital mortality. And this was a 4-hospital pragmatic before and after intervention trial. E-cards actually works reasonably well, and is one of those few scores that predicts for cardiac arrest, ICU admission, or mortality that's been validated externally. And how it alerts, well, it's embedded within the EPIC, so the physicians and the nurses will be able to see actually these scores when they look at their patient, and the little red dot appears on the patient list when it shows. And there is an alerting system. They don't go straight to the physician. There's a buffer. It actually goes and asks the nurses to repeat the vital signs and confirm. And if it's still high, then they have the option to escalate to the physicians. And they did find that there was a decrease in mortality for those patients in which the e-cards indicated a high or intermittent risk of an event happening. But there's a cost. 12% of the patients had an alert, which is actually relatively quite high if you can imagine the size of your hospital, okay? The other is that this is a before and after study. So one problem with that is that it oftentimes, you don't know how much of it is the intervention versus a secular change in time. And that actually was looked at a little bit better in this study by Vincent here and Gabriel Escobar, looking at the advanced alert monitoring. This is another early warning score to try to prevent patients from progressing to ICU, critical illness, and death. It was validated again in multiple hospitals within the Kaiser Permanente and has good performance. They selected a cutoff of 5 or more, which indicates an 8% risk of deteriorating over the next 12 hours. Now, sensitivity was only 49% of that, but that's something that you'll often see in these models. You have to balance the sensitivity, how many patients you're going to be able to detect, with how much false positive it may end up generating. And this was implemented in a stepped fashion. So it's better than the last trial in that it's not just a before and after. They actually accounted for the time trends across these different hospitals. It wasn't quite randomized, but it's an improvement in that sense. And again, they had a buffer. The alerts didn't go straight to the clinicians. It went to a specially trained nurse who remotely will then review the charts and the patients, and then if they see it appropriate, will escalate to the next level, where they will contact a rapid response nurse on the ward, who will then maybe evaluate the patient and then escalate to the physicians as needed, okay? And they did see a significant decrease in mortality as well as ICU admission that was seen in those patients that alerted, and while there was no change in those patients that were not alerted. All very encouraging, but again, you see there's one new alert per day for 35 patients in the hospital. So you can imagine, depending on the size of your hospital, why it might be helpful to have a separate team that's funneling all of these alerts. So this is another one. This is looking at a machine learning algorithm that analyzes the calls to a dispatcher for an emergency and seeing whether or not it would be better at analyzing the speech to detect an out-of-hospital cardiac arrest. The goal was that these models will analyze each of these calls, and then if they could indicate as a high risk for out-of-hospital arrest, then alert will come on for the dispatcher, and the dispatcher has the option to ignore it or to immediately send an ambulance or a physician vehicle, a physician staff vehicle for the out-of-hospital response. And this was unblinded randomized controlled trial, 654 out-of-hospital cardiac arrests is detected by this algorithm. The performance was okay. It actually had a high sensitivity, but only a little bit higher than the dispatchers were able to pick themselves. But the dispatchers had better specificity. They were better at understanding when a call wasn't a cardiac arrest, which is majority of the calls. So ultimately, they found no difference in terms of recognition of out-of-hospital cardiac arrest, no significant difference. But if you look, the dispatcher were already doing a pretty good job. They picked up over 90% of the out-hospital cardiac arrests. And the downside to it is that they hit a huge amount of false positives, 7 out of 8, okay? A high false alert rate of 82%, which is the other dark side of this. And this is the last one that I want to kind of highlight. This is a HYPE randomized control trial that looks at early warning system of in the operating room using data from an A-line on patients with intraoperative surgery, elective surgery, non-cardiac surgery. And it's to predict for hypotension. It performs actually really well in terms of discriminating between hypotension within the next 5, 10, and 15 minutes. And at a score greater than 85, the likelihood of a hypotension occurring in the next 15 minutes is about 85%. So this was a single center, unblinded, randomized controlled trial of only 68 patients. What happens is that the anesthesiologist will see on a monitor all of the vital signs and the physiology on the patient, including the stroke volume, the resistance, stroke volume variability. And when actually you see the score goes above 85, it turns red, and then the anesthesiologist is asked to act in the next 2 minutes. And they have a structured algorithm for how they should act when that happens. They did find significantly less hypotension, okay, and a shorter time to reaction and treatment, but they also saw a lot of alarms, 12 alarms per patient. 14% of them were ignored because they already did something for the patient or because they was like, that's it, I've had enough. So these just give you some examples of what's needed to try to understand whether or not it's going to help or not help the patients. We're beginning to see more of these randomized controlled trials, but really more is needed. And it's needed because you really need to understand the efferent, and sometimes actually much more importantly, the afferent arm of how it actually elicits action and whether it helps the patient. Significant limitations, high false alarm rate, okay? Oftentimes you need a buffer, so there's still another layer of human evaluation to try to cut that down. But the other thing that I wanted to highlight with these studies and these trials is that they're almost all single center or single healthcare systems, okay? And that's a little concerning because we don't understand what the generalizability is beyond those systems. And it also may highlight more disparities because these are the hospitals that have the resources to be able to do this AI and to be able to get another team, a remote nurse or whatever it is, to implement them. And this may actually further health disparities going forward if they really are as useful as we hope they to be. The other is an issue that actually Jan had brought up. None of the clinical trials that I just presented even had race on their table 1, which for most of our clinical trials is kind of like basic things that you have to report. And given that we already have data about disparities in terms of monitoring, like, oxygen saturations in blacks and whites, this is going to be a real problem. And I don't actually think journals should be accepting papers that don't report race on using AI. And with that, thank you for your attention.
Thank you, Michelle. I was struck, I have to make a disclosure myself, is that, I'm not an expert in this field. So I consider myself sort of a unbiased arbiter or observer here. But as an editor, I can tell you that in the literature, we have what seems to be sort of the human equivalent of big data AI is the retrospective case series, where we look through our own data or else's data and put together what we feel are correlative or associative findings. And you think about it when you take a step back, how often does that really change medicine? How often do we move forward? And the answer is very rarely, if ever. And more often than not, such data reporting actually just increases the noise in the system. And we have trouble finding out how to move forward until we get a truly well-done prospective randomized trial. And it's disconcerting to hear that AI has not yet really moved forward yet in being able to penetrate that reliably to give us prospective, good quality predictions.
Yeah, and I think that's what we're all kind of looking for.
Yeah.
Right? But I also want to emphasize, actually, however good your AI is, if your afferent arm, like what happens with the AI, what you do with it, is ineffective, then you may not still see a benefit. It's a tool, it's colleague, as Vincent say, a tool, but we know which colleagues to turn to and which colleagues to actually, turn away from sometimes. But the same happens with AI.
Right, and the transparency, as was mentioned earlier, is a big problem because we don't know how the data algorithms were set. Mm-hmm. We really don't know what's coming out. Thank you. I'm sorry, if there's any other pressing question for Michelle, please raise your hand. I didn't mean to steal anyone else's questions. Okay, I guess we can move on.
Okay, thank you.
Thank you.
So now it's my pleasure to introduce our next speaker, Edward Schenck from New York, who will tell us about machine learning and identifying subphenotypes.
Okay, thanks everyone. I'm going to take a little bit more of a historical perspective on what we mean by subphenotypes and bring about the promise of machine learning. I am as I said yesterday in my talk, I am a skeptical enthusiast for all of this. And so there's promise, but as we can tell from the COVID-19 pandemic, machine learning was not how we saved lives for the most part, and I will bring that forward at the end. I have no relevant disclosures for this talk. Okay, so the central idea of this talk is, can we improve syndromic definitions of the diseases we treat in the ICU? And the answer is that we can change our concept of these syndromic diseases and we can refine them, oftentimes with forward-thinking machine learning. However, that is yet to translate into anything relevant clinically so far. And so the reason why we have to do this is because, especially for critical care syndromes, is that we have been severely limited in the past 30 years in terms of how we translate our hypothesis-driven phenotypes and sepsis models. For instance, this example of animal models, or actually other, mouse or other large animals. The idea of the TNF inhibition with monoclonal antibodies having these incredibly enticing rescue from a poor outcome. And then we see the follow-up repeatedly, and this is from the 1990s, in that with large-scale multi-center clinical trials based on the hypothesis-driven model in our clinically derived syndromic definitions of diseases, we do not see improvement in our outcomes with these targeted therapies for our conditions. And the reasons for this is a framework that I think about often in terms of how I think about how machine learning can help us, is that we really do not understand with a lot of our syndromic diseases the timing and the state of our patients that we see in front of us, and that the level of complexity for these types of patients is overwhelming. We have an infectious insult, and we have variable arrival into our treatment centers, and we have variability in terms of each individual host response, and variability in terms of the response to the therapies that we're giving. And underlying it all is there's the complexity of each of us in terms of our genetic variability, our age, our epigenetic changes influencing our immune states, our prior infectious status, our comorbidities, and even we're learning about more things that are as complex as our microbiome, which we're just starting to understand. And however, if we get back to our syndromic definitions, we approach them almost completely with complete simplicity, in that the idea of sepsis is someone with an infection that might die. And then if we take a step back further than this, in that, from the earliest recognition of gram-negative sepsis, if you go back to the 1950s, this is from Max Weil and Wesley Spink, is that heterogeneity has always been known for these clinical syndromes. In that heterogeneity in the presentation of septic shock with hypotension is that you have some patients who are cold, and you have some patients who are warm. And that in the evolution of their septic shock, needless to say that the gram-negative sepsis was different in terms of these early investigators from gram-positive sepsis in skin and soft tissue infections in terms of who was at risk and what their comorbid status was. And also the change in flora due to antibiotic administration in the hospital. And that they also saw that the time course of the response to septic shock was variable, and that some people developed uremia and acidosis and some people did not. And so heterogeneity is part and parcel with what we do. And when we simplify definitions with scores like SOFA scores, and so this is the definition of sepsis currently, if a clinician orders a body fluid culture and an antibiotic within a constrained period, and there's an increase in your SOFA score compared to a baseline, you have sepsis for entry into a clinical trial or for epidemiologic purposes. And then we look for the heterogeneity of treatment effect in terms of our more modern clinical trials, and we stratify by things like level of SOFA. So these are examples from two recently published clinical trials, the first one being variability in terms of fluid strategies, and the second one being the administration of vitamin C. And so we explore heterogeneity of treatment effect around severity of illness as defined by an organ dysfunction score. And then this is just a chart of the challenge within defining syndromic disease processes this way, is that these are your level of SOFA score on the x-axis here, and then each one of these numbers is the number of possible combinations of SOFA score as you move through the level. So if you have a score that ranges 0 to 4 with 6 different levels that are each independent, as you get towards the middle of these scoring systems, you have an overwhelming number of combinations of scores. And so how do we deal with this? So this is a paper that made me fall in love with machine learning and made me fall in love with data science. And it was at a conference that I attended, I guess almost a decade ago now. And so this is the idea of taking SOFA scores and combining them with age and using a relatively primitive machine learning methodology to cluster patients. So each one of these nodes is a patient. This individual SOFA score value is with the intensity of the node color. And then you take each individual 6 SOFA subscore together with age, and you find clusters of individuals in which combinations of differing SOFA scores assign them to that cluster. And so this is a way of creating patterns of SOFA scores that differentially predict prognosis, meaning that the prognosis of each one of these clusters is 1, 2, 3, and 4. It is different, and the patterns of organ dysfunction and the patterns of age are different within each of these individuals within the groups. And then this is followed up with more modern machine learning methodology and more comprehensive clinical features or parameters. So instead of just SOFA scoring, you're looking at inflammatory variables and other comorbidities and patient characteristics, coming up with differing subphenotypes of sepsis. And you can see that there's differential patterns of organ dysfunction and inflammatory and other variables that create each one of these phenotypes. And these also track very well with differential outcomes. And there's the hint that they can predict differential responses to applied therapies. So moving on to other diseases, the rest of the ICU community is starting to kind of catch up with what we've been doing in the sepsis world. So this is an example of using cardiogenic shock patients and looking for machine learning derived patterns to classify groups of patients with cardiogenic shock. You have differing levels of right atrial pressure and heart rate. These are radar plots here, at different levels of acidosis in terms of metabolic and hemodynamic variables. And within these groups, you can see differential responses to mortality, and this is repeated in these non-congested phenotype, cardiorenal phenotype, and cardiometabolic phenotype in terms of their outcomes. And if you add these data together with traditional shock stages, you improve the predictive performance. And then into other disease states, ARDS through the UCSF group and others using latent class analysis, which is a differing machine learning technique to classify patients as hyper or hypoinflammatory subphenotypes, have been repeated and validated in robust manner retrospectively many times, and there's the hint that this may lead to predictive enrichment. And as you move on to, instead of heart, lung, sepsis, that there's also these clinical subphenotypes of acute kidney injury. These are the combination of actually biomarkers together with clinical factors, creating using latent class analysis to identify differing phenotypes within clinical trials of kidney injury. And the interesting thing is that there is the potential for a differential response to vasopressin therapy. And so just to go back to the explicit representation of concealed heterogeneity with when we try to look at things like a SOFA score strata cutoff, is if you take the combinations of SOFA score at a level of 9 and perform just clustering restricted even within that level, you can see that there's differing patterns of organ dysfunction. So this is not including age, this is not including any other clinical feature, that you have groups of pulmonary and neurologic failure, you have cardiovascular failure, and you have more mixed organ dysfunction. And these identify very different groups of people. This is just with observational data, but you can see differences in age, you can see differences in ICU wing distribution, you can see differences in comorbidities. These are all patients with sepsis. And then you can see differences in levels of immunosuppression, even within that one strata of severity of illness. However, these are not differently prognostically. So this drives home the distinction between prognostic enrichment and predictive enrichment. And so we can also look at the biology of our diseases, of our syndromic diseases. And just very briefly, in looking at peripheral blood leukocyte transcriptomics, you can see that differing pathways of inflammatory changes can be highlighted, such as T cell activation, cell death, apoptosis, and necrosis, being important in the circulating leukocytes in terms of clustering patterns of transcriptomics. And this is an example from the Julian Knight group in the UK. And this has been kind of synthesized in terms of across sepsis related leukocyte transcriptomics in terms of differing phenotypes of these patterns of gene expression. And so in conclusions, there are distinct subphenotypes in clinical care syndromes through the analysis of clinical and biologic samples. And several of these methods identify patients with plausible groups of conditions that may respond to therapy differently. And prospective replication using these methods and most importantly, clinical trials based on these methods are needed. But as a note of caution, is that the hypothesis-driven model of COVID progression that incorporated the time since viral infection. So this idea that was a completely heuristically driven model of the human's response to COVID infection, meaning that there would be an early viral response phase that moved together with a host inflammatory response phase. And this was just based on our known immunology in terms of responding to viral infections. But this was not based on machine learning. And when we did large-scale clinical trials in treating COVID-19 patients, the heterogeneity of treatment effect was largely dictated by time in terms of the relative response to infection. So if you had, this is just an example of this, if you had corticosteroid therapy when you did not have oxygen, implying that you did not have the inflammatory response or the viral, or you did not have pneumonitis, that there was no survival benefit, and this also is carried forward with therapies with monoclonal antibodies and convalescent plasma, is that if you were in the viral response phase, you benefited from antiviral therapy or antibody therapy, whereas if you were in the host response phase, you benefited from immunomodulation. And so this is, in 2020 when this came and machine learning was almost ready, but our heuristic-based traditional viral understanding was also ready. The tradition beat the machine learning, 10 times to 1. So with that, I will end. Oh, and so conceptually, though, this is a model of kidney injury with just theoretical differential trajectories of creatinine. And this is a machine learning-derived model of temperature trajectory in patients with sepsis that is predictive of differential outcomes. And so in the future, we may be able to incorporate time into our understanding of these diseases. Thank you.
Are there questions from within the audience? No? Maybe then I will kick off. So you told us that in this way we will be able to identify certain types, but how do you see that this will lead to interventions in clinical practice so we can detect? But will this lead to therapeutic interventions? How do you see this?
So this gets to the idea of incorporating either specific patterns of disease that, so potentially if there is a coagulopathic pattern of sepsis, for instance, with more DIC and certain types of organ dysfunction that you may want to, if you identify them with accuracy, you may want to enroll them in a clinical trial for therapies targeting that specific disorder. So potentially that is how you can incorporate this into the more rational use of clinical trials.
Thanks, Edward. Our next speaker will be Dr. Alexander Vlaar from the Medical Center in Amsterdam. Welcome.
Thank you very much. Yes, so thank you for the invitation and to be here also and with this large group of audience. So how AI can prevent hemodynamic crisis. So these are my conflicts of interest. So a hypertension in the ICU, this is what we're going to discuss. Is it present? Machine learning and hemodynamics and ongoing trials and future perspectives. I think something what already was mentioned also by the previous speakers, we need trials in this setting. So hypertension in the ICU, first of all, the question is of course, is it present in the ICU? Because when we started this research, we were thinking, are we doing quite fine in our ICU? And I think we're doing also quite fine. But if we look at hypertension and we define it as a blood pressure map below 65 millimeters mercury for 1 minute or more, there are more than 140 definitions of hypertension worldwide, but this I think is one of the definitions we mainly agree on. Then, of course, the question is how often is this the case in your ICU? So approximately 500 ICU patients, we prospectively follow them in the first 24 hours. We take an 8-hour time frame with really waveform beat-to-beat analysis. This is quite an issue in hypertension management that people have not beat-to-beat measurement. In a mixed ICU population, we measure there. And only 25% of those patients suffered no hypertension, with 75% having hypertension with a duration of 52 minutes in this 7 to 8 hour time frame. So that's huge. And first we thought like, oh, geez, this is terrible in our ICU. But luckily other people have been doing this as well and come up with the same numbers. So this is probably the case also in your ICU. And then the other thing is, of course, what are nurses doing or physicians when this occurs? So we had some research students and we told them that they should say they were looking for food or diet research in the ICU, but actually they were looking what nurses were doing and physicians when hypertension occurred. And what you see here is that 75% of the nurses are not doing anything in the first movement when an hypertensive event occurs, because we know that often after some time wait and see, the hypertension recovers again, so you could just wait and see. The question is, of course, is this good? Because we know it's associated with poor outcomes, so we think you should act. But this is the practice we have. We have a very reactive setting, and when it's really going down, then people start to act. So, and then still what I was mentioning, so what? This 63, 62, 55, so what? Well, if we look at meta-analysis we also performed, then it is really associated with poor outcome, with cardiac, with renal, with neurological, surgical, and even with mortality and hypertensive event in your setting. So we also know next to acute kidney injury, myocardial injury, mortality, it is associated with incremental depth and duration. So what the issue with many trials is, I think we have seen many, they do not a prevention of hypertension, they do a treatment, and often they do just one approach, so or just only fluids, or are we going to give them only vasopressors? But we really would like to have a personalized approach in this setting. So next to that, we need a machine learning algorithm to detect or alarm the physician or the nurse. We also need to have a personalized approach when this setting occurs. So where machine learning and hemodynamics come together. So machine learning is already very old. So I think it's now also becoming a kind of a hype and everybody thinks it's something totally new, but it's in a way, it's just statistics. It's a bit more complex, but often also very simple statistics like logistic regression can still be done in a setting of machine learning. And we have unsupervised and we have supervised learning. And this is, of course, what we really know. We know those images, this training, and we understand it very well. But if we go to a clinical setting, for example, to waveform analysis, things become much more complex for people. And why is it now so hot? Why is it such a hype? Well, first of all, we have a lot of data. So we can start calculating on things. And on the right, you see the computer power. We get much more computer power, so we can also do things with this huge amount of data. And that's why you get more and more AI in your environment. So why do I think it's the ideal setting, hemodynamics? Because it's a very complex setting. There's a lot of data in the ICU and the operating theater. We have those waveform signals. There's a lot of information in it. And we, with our human eye, we just cannot detect and we definitely cannot process all the data we get to us. And we can perform management there, and we get a more individualized approach. So if you look in, for example, an OR setting, your time to treatment is 1 minute and 30 seconds when a patient already has hypertension. So actually, you would like to have this window shorter, or maybe even be before there. So we would like to know before it's too low. So it looks like we're looking in the future, but actually, it is already there in the data. So if you look in those waveforms, there is data in it, and we can extract it. The HPI is one of the algorithms, but there are many other algorithms now also coming out there on waveform analysis. So in this setting, there were 2,606,000 features which are in those waveforms, which in the end resulted in the final predictive model. And how do you do such a model? You do a training model, then you do a validation model, you do an internal validation, and in the end also an external validation. And I think this is an important issue. Then most of the studies stop. People publish a model, they say we can do it, but we need to continue. So here's the internal validation very well. What you see here in a case is that if a case becomes hypertension, you see already the algorithm giving an alarm, a high number, that this patient will become hypertensive, and in that way you are able to do something. So I think of AI really in a pipeline. You have your data acquisition that needs to be very good. So garbage in, garbage out. If you have bad data, everybody can build a model in the end and publish it. But if you have a low quality data, you will also get a low quality model. After developing the model, you need to do an internal validation. Then you need to do an external validation. And I truly believe we need randomized trials really to show the model in a real life setting is adding value to healthcare. And that's what we need. So one of the trials which was already mentioned, we did in our center, is the HYPE trial, which was published in JAMA a few years ago, looking in the implementation of a machine learning derived algorithm, and in a way it's a pilot randomized controlled trial. And what we looked is whether if we have an alarm, which can this algorithm do, with a diagnostic guidance, with a treatment protocol, would it reduce time spent in hypertension? And we use the time-weighted average, which means it's a correction for the time, but also the depth of hypertension, which I mentioned. Both of them are important. So TWA is the number we look at, which is something for clinical maybe not what you will be using in daily practice, but if we want to compare studies, compare effect size, it's a very important factor. So what our question is, does HPI reduce the time-weighted average spent in hypertension during surgery, and does the availability of HPI together with suggestion of the cause of hypertension change treatment behavior? Again, this is the TWA, so we really would like to know what this area under the curve is. So we had 40 patients in phase A, which was blinded. We wanted to know whether there's a Hawthorne effect, so which means that if you start talking about hypertension, people start treating or behaving different. And then we had phase B with 60 patients. Is there maybe some water? Could I have some water? Oh, there it is. Yeah, thanks. So these were the inclusion criteria and exclusion criteria. And this is this treatment protocol. So you need a treatment protocol because if you only alarm and you're just sitting there and you don't do anything, an algorithm will not help you. So the bedside anesthesiologist they were advised whether there was a vasoplegia and hypovolemia or a contractility issue, and they had to start treatment. These were the eligibility criteria: 284 patients screened, 121 included. So what you see here is that the presence of a machine learning derived algorithm alarming system plus a diagnostic algorithm and a treatment algorithm significantly reduce the time-weighted average of hypertension, the area under the curve of hypertension, the incidence of hypertension, and the percentage time of surgery spent in hypertension. The other thing, of course, what we wanted to look at, is it causing more hypertension? So are we now just increasing the map and in that way preventing hypertension? That was not the setting. We are not causing more hypertension. What you actually is seeing, people are doing small interventions based on the alarm a bit more often, but they can do little intervention and in that way prevent. So what we know in healthcare or in medicine, if we prevent something, it's better than curing it at the end. So what we, I think, all know, if a patient is really crashing, we give fluids, we give vasopressors, everything. It's not yet happening, so we give more, and then at the end you get an overshoot. So this is a much more personalized, titrated medicine. This is what you see here. Cumulative dose of medication fluids is not different between the arms. The other thing, and this is the difference, I think, with some of the trials, because there are also negative trials with this machine learning derived algorithm. And what very important is to look at is the compliance. So the previous presenter was saying there was still some refusal of advices about maybe 20+%. You can look at it half full, half empty. And there was almost 80% compliance with the alarms going on and the advices, which is huge, I think. But this is very important. So if you look at a negative paper, in any machine learning derived algorithm or machine learning trial, look at the compliance of the alarming system. If people are not following up the alarm, of course you will have a negative trial. So ongoing trials and future perspective. So what you see is we need validation of the algorithm in the ICU because it was trained on ICU data also, but it was only first validated in an OR setting in our center. But we have done this. We have done it in COVID-19 time, so we continued our research. Here you see it's working in an ICU setting with COVID-19 patients. What you see if HPI goes up, we also did it in a 500 patient database, mixed ICU. If HPI on the x-axis goes up, you see the event rate going up with a very nice slope. So what now, of course, the question is, we've been able to show it works in an OR setting. Will it work also in a much more complex setting, such as cardiac surgery? And will it work also in an ICU setting? Because this is, I think, where we also, at this conference, are, of course, very interested in. So the HYPE 2 is a successor of the HYPE 1, which I already showed and was briefly also discussed here. And it showed this huge impact on hypertension. So it's the first randomized trial using HPI in cardiac surgery in ICU patients. As already mentioned, we know hypertension is associated with increased morbidity. Why did we choose cardiac surgery? Well, it's of course tricky because it's a very complex setting, but we know hypertensive events is most present in this setting, and that's why we choose this patient group. We enrolled patients 80 years or older for elective cardiac surgery, and they received standard monitoring, and of course the anesthesiologist and the OR team and the ICU team on forehand should not say, no, I want to have a blood pressure of 60 or I want to have a blood pressure of 80. They should agree on a 65. Majority was always the case in this setting. So we started the trial after induction at the start of sternotomy because the algorithm is validated only in a continuous setting, not during the induction period. 50 minutes before pump time, we stopped the trial because then the blood pressure is always lowered during the cannulation phase, so it's not fair. During the cardiopulmonary bypass time, there is a laminar flow, so it also is not making sense to apply the algorithm. And then 30 minutes after pump, when there is a bit of stabilization, then the trial started again till closing because then the patient moved to the ICU. And then from the ICU till extubation or 8 hours after admission, it was followed up. We do a follow-up of 28 days for complications. So in the OR, again, there is this diagnostic guidance algorithm. When HPI goes up, so the number goes up, the likelihood is high, hypertension is occurring, or a MAP below 65. We already asked them to look at the secondary screen whether they find some indication where the cause might be. And that can be, again, based on the criteria, vasoplegia, hypervolemia, or reduced contractility. Of course, they were allowed to use ultrasound because that's in place also in the OR. It's a really add-on on standard of care. And of course, the crazy thing in the beginning is with physicians, they need to start treating something which is not yet there. So that needs to take some time, and the best way to do it is just give people the algorithm and tell them, if you love it, it's okay, and if you don't like it, bring it back. And they always come back, well, the algorithm actually was right most of the times. So that's the best way to convince people, instead of say, you need to do it. The nurses, it was different. So in the ICU, we believe we did a survey worldwide in ICU, whether people would feel okay with treating hypertension autonomously by nurses. I don't know how it's in your setting, but at least in our setting, it was often that if a patient became hypertension, the physician was called on the ICU. The patient is becoming hypertension. What should we do? Should we start vasopressors, fluids? Should we start inotropes? Can I get an order because there is not yet something? So there's a huge delay. So if you want to apply this algorithm, you want to use those minutes the algorithm gives you to start treatment. So that's why we decided up to 2 interventions the nurses can do themselves. So it's a totally nurse-driven protocol in which they can go through the display, the algorithm, and either give fluid bolus or give vasopressors. Within a range they are allowed to start themselves. Inotropes, they are allowed, if they are running, also to change them themselves. If they would need inotropes, because it's not yet there, they need to contact the physician, and vasopressors for afterload, they can start them themselves. After 2 interventions, they need to contact the physician because, of course, as physician, you still would like to know if your patient is going into a hypertensive crisis and some interventions are given. But at least it gives autonomy and also the ability to intervene fast. So we just finished the HYPE-2 trial. Data is now being analyzed, so I hope next year or in another setting to show you the data. We're really looking forward to it because I think it's a very important trial. Of course, those trials, they show the algorithm works. They show we can prevent hypertension, we can reduce it, but really the final proof is, of course, that we also are able to improve the outcome of those patients. And I think this is the next step we are, but I think for a dynamic setting, applying machine learning this way, it's the way to go. So hypertension is related with poor outcome. Hypertension is a serious problem. We all recognize that it's a problem. AI can help us. It will not replace us. It can help us in alarming and identifying the issue. And I'm hoping to share soon with you HYPE-2 results. Thank you very much.
Any questions?
Here's a question.
Yes, good.
All right. Thanks for your amazing talk and amazing work in this trial space. Any thoughts with the randomization schema? Is this individual patients randomized at a time? And did the teams, specifically the nursing staff, if it was individual patients, how did they react to having some on an algorithm versus some off the algorithm at the same time?
So it was one-to-one randomization. And do you mean that in a bay there could be a patient with an algorithm and a bay without an algorithm? Yeah, well, they're totally fine at this time because the standard of care is no algorithm. We always had some assistance with starting up such an algorithm when the patient arrives because I really truly believe that we first need to show if people really are compliant, it works. And this is what we're doing. But there are no issues so far. Yeah.
I had one comment. as an anesthesiologist and critical care physician, sometimes, I believe that we as a human species are often quite lazy. And if you introduce algorithms where little blinking lights tell us that something is amiss and we need to act, we tend to wait for that to happen. And I'm trying to think, with this scenario, what's worse, a patient who goes underneath the MAP value you prescribed and we act upon that, let's say 65, as opposed, assuming that your instrument interprets, for example, the A-line tracing well, and it can discriminate the differences between a brachial, radial, and femoral A-line, which are quite distinct. But secondarily, what's worse, an interval degree of hypotension that is clearly going to be seen because the lights are blinking, and it's treated appropriately, versus the patient who is at a MAP of 66 or 68 for 15, 20 minutes. And I would consider that hypotension, because it's showing a patient with a, systolic pressure of 85. So we as physicians would be waiting for the blinking light and perhaps not anticipating that, geez, that patient is sulking there at a very low blood pressure, and we are guesstimating that 65 somehow is good for that 75-year-old woman who's never seen a blood pressure below 150 over 100 for 20 years before she came into the hospital. So I think we need to have a lot of work to define the patient population and, more cautionary notes of how we're using that data.
Well, very important, I think, remarks. So first about the alarming. The interesting thing is that if you use such an algorithm, some people start reacting like, then there's another alarm. But actually it's reducing your alarms, because we show it. If you prevent the hypertension occurring, the nurses get less alarms. So this is also a reason how we convince them, like, you will get an easier job if you just follow the algorithm. And that works. Okay. The other thing is about all the things you're mentioning. We can do it already. We can do an individualized approach. It's even possible technically already that the machine learning is improving itself based on the features of the patient. The only thing is, I think the regulatory authorities are not yet there, that they don't know what they're approving. If they're approving a dynamic machine learning model, they cannot deal with it. I think the technique is already ahead of what regulatories and we as physicians can understand or want to understand.
Gotcha. Okay,
Yeah.
Thanks. Anything else? No, well, thank you very much.
So we now welcome our next speaker that doesn't need a lot of introduction, Professor Pinsky from Pittsburgh, and he will continue on the hemodynamic management.
Thank you very much. I'm reminded by Luciano Gattinoni, who said to me, I'm not worried about artificial intelligence, I'm worried about a lack of natural intelligence. And the point is, thank you, that there's no substitute at this present time for an intelligent physician observing or clinician observing the patient at the bedside. Everything else we do is associated with that. These are my conflicts of interest, and they're directly related to what I'm going to talk about, because everything I've ever done is related to hemodynamic monitoring. But importantly, I'm the inventor of 2 U.S. patents. The first is the dynamic arterial elastance, which you saw in the last lecture is being used for the algorithm. But the second is that we have an approved patent on looking at complexity modeling to identify critical illness. And that was a patent that I submitted primarily so that it didn't have to be defended, so that no company could make it theirs, so that everyone can use artificial intelligence to manage patients. So that's just out there, okay? So don't be surprised by the unexpected. Prepare for it, but can be predicted. When we're talking about using artificial intelligence for hemodynamic monitoring, what we're doing is we're not using new tools, we're just looking over time. And if you look at the exact same data over time, evolving patterns become obvious with no change. This is a picture of the night sky. I haven't changed the night sky. I haven't changed the way in which you look at it. I've just looked at it over time. And as you see from this, there is an evolving pattern that demonstrates exactly where the North Star is, for example. So let me give you an example of evolving patterns and how we can use machine learning for it, and then the principles behind it. Nobody talked to you about the principal components and the featurization, but what we do in machine learning is we take a waveform and we look at all the different features that are from it. And then using machine learning, because the computer can do it, we look at multiple 100,000 correlations. You could have done every single one of those correlations yourself once, but it would take a lifetime to do the 100,000. But machine learning can do it in a couple hours. So that's the reason why we use these models, is because they're doing statistical analysis and looking at things, and they tell us what's useful. It is then up to us as human beings, as doctors, to say, is this rational, what they say? This is an example of a human being in our lower body negative pressure chamber, in which all we have done is increase the degree of negative pressure in the box below their abdomen, which is the equivalent of hemorrhage. Every 10 millimeters of mercury drop is equal to about 400 mLs of blood loss. And as you can see, as you progressively increase the box to more and more negative pressure, the stroke volume progressively falls down, but the blood pressure remains constant up until the end. What I want to show you is the non-invasive measurement of pulse oximetry. And if not looking at the oxygen saturation at all, I really don't care about oxygen saturation because it's almost never an important issue in my patient. But if you look at the pleth signal itself here shown, and I were to show you a little bit closer, you can see how as you get lower and lower in terms of your stroke volume with the same mean arterial pressure, the change of the pleth occurs with loss of reflected waves. Interestingly, we do the exact same data collection, but not during lower body negative pressure, but during air transport of critically ill people from a scene. And this is an example of one patient who was emergently intubated on a helicopter, and you can see the exact same mirror image of that featurization in them as well. So this is the sort of featurization that we're talking about when in my lecture I'm asked, what is the hemodynamic monitoring that we should be doing? It isn't that we're using a pulse oximeter, it's what are we doing with the pulse oximeter's information, okay? That's not the same thing. So I'm not gonna go through all of these, there's not enough time in my 10 minutes, but we can early identify, I will show the triage, what can be done, and this is being done right now. I can tell you who is not going to be sick when they're admitted to the hospital within 15 minutes of them being arrived, and I can tell you for the next 2 days they will never crash. I can tell you that with great accuracy in patients admitted with trauma and post-op surgery. I'll show you that in a second. We can do latent group analysis, which is simply saying that we know that there are different subgroups of people. For example, ARDS, we've always talked about primary and secondary ARDS, right? So it's not surprising that the two look different. But within each one of those, there are subgroups as well. And we can use it for prediction. We can have smart alarms. One of the things we focused on from the very beginning was to eliminate artifacts in real time so that when the alarm goes beep, it's real. It's because we wanted to eliminate alarm fatigue. And that's what I spent the first 5 years of our work on this, working on from a technical perspective. And then finally, we have intelligent clinical decision systems, which is I'm working on now. In an open loop system, patients, the physicians, clinicians can reject it, but there is zero rejection if it's a closed loop system. So you have to make sure they're very accurate. So I wanted to talk to you about predictive analytics. And it was said earlier, you can't predict the future. But you can identify subtle subliminal things that are present in the data right now that are signatures of what's going to happen in the future. And that's going to be a lot due to the nature of the patient, et cetera. But you can follow these things nicely if you have adequate data collection and you're looking at it. To be able to identify exactly how somebody is right now, we refer to as nowcasting. But to predict who will crash based on data, that's forecasting. So Gilles Clermont and Fu Mandeli, when she was with us before going to Johns Hopkins, looked at the respiratory heart rate variability metrics, multiple features. And we knew that some patients were going to crash and others weren't. So in the training set, we identified what were those features that were present in the heart rate variability that were seen in people that would crash and wouldn't crash. And then we took about 200 patients that were part of our training set, and we ran it on them as well. And we walked backward from a code being called for cardiorespiratory insufficiency backwards. And this is over a period of 10 days. And this is an important point. We were able to clearly separate out those people who would crash from those people who wouldn't crash 48 hours beforehand. And this is universally seen across all data analysis. Very rarely do patients who are crashing of their own volition, not surgically, do it over a minute or two. It takes hours, and you could see it if it's there. And what we saw was they could separate them. Patients who had a high level of heart rate variability based on our features were healthy. The lack of heart rate variability was bad. We talk about stability as being good, but I assure you there's nothing more stable than death. What we have is we have a baseline level of stress, and let's assume somebody's getting sick, and that's whatever the metrics are, and at the present time, we don't identify 80% of the patient when they reach the level that we should see them. We've already heard that. This is our current performance, but with appropriate nowcasting, we should be able to say that when the machine goes beep, see the patient and they're sick. And that would, of course, allow us to treat earlier. And if we looked at subliminal things that would not be considered abnormal, we could move that time to an earlier point, and therefore I need less effort to treat the patient. It's now been 11 years since we performed this first trial. Using Oxford Biosignals analysis of our own data, we created an artificial neural net with just 3 nodes to look at pulse oximeter, O2 sat, heart rate and respiratory rate and intermittent blood pressure to determine about 300 patients in our step-down unit if they were healthy or sick over time, and we had it in a display. The sicker they were, the vital sign index got bigger or smaller as a balloon, and the balloon itself was a pie, and whether it was respiratory rate, O2 sat, blood pressure, or heart rate, determining the pie getting higher would be there so they could kind of see it. And so before we started it, we did a sampling of our patients in the step-down unit to say how many times was the medical emergency team activation occurred, and how many of the times was it minor, it was something you could have fixed, and how many times was it major and I would have called a code. And then after we'd done this for 6 weeks, we took those data and created a model and showed to the nurses at the bedside in real time that same number. And we said, no more Mr. Nice Guy. If this machine goes beep because the number goes above 3, you absolutely positively have to see the patient. If you can't fix them, call a code. And that's all we told them. And by the way, we didn't tell the doctors we were doing this. And what we found was that we didn't decrease the degree of minimal instability, but we profoundly decreased the number of patients who went on to a full code. And the nurses told us that the ICU became quieter, all the other alarms stopped working because the patients were stable and they had more time to take care of their patients. We decreased the alarms by 50% of all the other vital sign alerts because we didn't take away their alerts. And furthermore, what we really did was it was able to treat the patients earlier, but when they were really sick, it took the same amount of time to take care of them. Okay. Looking at that data, we were able to ask the question, when they first came into the step-down unit, after they'd been there for 15 minutes, we just took 15 minutes of data, and we said, in a training group, we knew they'd eventually crash. In another group, we knew they wouldn't. And we're talking heart rate, respiratory rate, O2 sat, and one blood pressure measurement. And based on this, we were able to create a signature of what we consider to be stability and instability. And if you looked at them at the 4 hours beforehand, and then we could identify accurately who would never crash. And of course, when they finally did crash, it was higher, but they were already unstable. But we were able to do this in 80% of the patients. We weren't trying to identify stability, but it turned out we could identify stability very well. But it was hard to determine when they would crash because they were already at a higher level. So if you looked at that exact same data and said, let's make it their normalized data, it doesn't matter what it is, we're going to say it's normal for them. And then you look at what happens when they go on their normalized data, not changing the data one bit. Now we had the ability to identify forecasting. And we could identify it in more than an hour and a half beforehand. And furthermore, if you look at latent group analysis, there were 5 separate groups of instability that occurred. The black line is the stable ones, and that is disease. And in fact, the groups were different in terms of their demographics and how long they needed to be at baseline risk and different times in the hospital. So in disease, you follow certain pathways. Which pathway you're on at this moment, I don't know. But within 15 minutes of seeing you, I can tell you which pathway you're on. And these latent group analysis can be done for other groups. Soojin Park, who will be talking after me, graciously allowed me to be a co-author on her paper, in which we looked at the endotypes of COVID-19 patients in the ICU, and we were able to separate them into 4 separate groups, and they were completely different in terms of their demographics. So now let's go on to my topic, which is hemodynamic monitoring. Okay. The real question that I like to talk about is hemodynamic monitoring parsimony. Now, I'm a big believer in the rule that the one who dies with the most toys wins. But that is not the way I should manage my patient. I should use the minimal data set necessary to identify what it is. And so we define that as what is the minimal number of primary variables and their featurizations that are necessary to identify disease, and what is our sampling frequency? Is it once an hour, once a year, beat to beat, or waveform? When you see your doctor as a healthcare follow-up, it's usually once a year. That's not going to be good in the ICU. But is 5 minutes good enough? Do you need beat to beat? And how long do I have to observe before I know what's going on? And I'll tell you right now, except for looking at it at a single snapshot, which tells you if you're alive or dead, single observations are close to meaningless. So we want to determine the performance. But how do you determine the performance of your ability to say somebody is sick or bad? And it's really not the area under a receiver operator characteristic curve. What you really care about is how many times does the machine go beep when there's nothing wrong? That's a false positive. Or how many times does it say you're fine and you fall over dead? That's a false negative. Those are the 2 things that count, and those are the 2 things that keep all of us up at night. So in a series of studies, we looked at all the hemodynamic monitoring we could do in an animal model of hemorrhagic shock. And they had a baseline value, and the reference is below. And then we started to bleed them at about 20 mLs a minute, 5 mLs a minute, or nothing. And at 5 mLs per minute, it takes like a half an hour before any change has occurred, anything you can measure. And then we looked at the features that describe the anomaly of those animals using a leave one out cross-validation random forest attack, so that anyone's in the machine learning, you know what I'm talking about. Never mind, we used fancy computer analysis to look at the data. And what we found was we could accurately follow the cloud of bleeding when there was no measurable change. That's for all the data. Do I need an arterial catheter? Do I need a central venous catheter, or can I use non-invasive metrics? That was the next question we asked. So using that exact same data, we looked at the activity monitoring characteristic curve, and you have to understand how this works. What you look at is the number of false positives, how many times the machine goes beep when nothing happened, and how fine after the event started did you get it. Now what you'd like to have, as soon as the event happens, the machine goes off and there are no false positives. What do the machines in your hospital do, the monitors? They have they're sensitive all the time. If you want to not miss a single time, have the monitor going off continuously. Because once there's an instability, the monitor will still be positive. But that's meaningless. And that causes alarm fatigue, but that's what we have today. So what you want is you want to have a low alarm, and this is the log scale. This is 1 in 10 times it's wrong, 1 in 100 times, 1 in 1,000 times. And over here you can see the various measurements. This is non-invasive measurements, the use of a central venous catheter, arterial catheter, the arterial catheter with cardiac output, PA catheter with arterial pressure. And you can see that if you have just looking at it every 5 minutes, you won't be able to identify bleeding until you're well into about 10 minutes into the bleeding with all of them. It's pretty poor. And this is the featurization of it. So if you just take 8 minutes as an example so I can give it to you as a reference, this is what you see. If I now instead, with the exact same data, don't look at it every 2 minutes, but look at the beat-to-beat variables, which allow me to cause greater degrees of featurization of it, you can see all of a sudden that at 8 minutes, I can be extremely accurate at predicting instability with 1 in 100 false negatives. That's clinically relevant. 99% of the time when I hear the beep, it's real. But that would only be with either the PA catheter or the PA catheter plus the art line. If I now look not at beat to beat, but look at the waveforms. And with the waveforms, what I look at is how they go. You can see now that almost all devices give me data equally. So across the line, if you were to see it, now with waveform data, a central venous catheter is useful. An art line is useful. So the question is, which monitor device you have? My answer to you is, how often are you monitoring it? Finally, if I know that the patient was stable before and they're now being unstable, this is the predictive value of simple metrics. That's every 5 minutes, beat to beat and waveform. And as you can see at 8 minutes, it's here. If I know what their normal baseline was, everything works better. Who would that be? Well, that would be a pre-op surgical patient, because theoretically they were stable before and then post-operatively. And when we looked at that exact same data, for those waveforms, I already showed you this is the waveform data without having a baseline. But if you had a baseline, everything works well. Central venous catheter still works. It's not the CVP I'm looking at, it's the features of the CVP. So we can actually develop this into a smart system, which we call IQ, which allows for the data to alert people ahead of time. And to get on to our chair's question, it's not a yes or no, it's a threshold thing. It's getting worse and worse, or they're getting better and better. And so in the future, we're going to monitor the monitors, but treat the patients. And we're going to look at artifact detection so that on the fly, as we're looking at it, the models we have will be more robust. And we'll use fuse parameters to assess them. And the thing we do at the University of Pittsburgh is we have a predicting instability time and treatment. It took us forever to figure out a thing that would call us to call it PIT. The PIT index, and there are the values down below, and there's the predicted thing, and there's our pie showing you which things are causing it. And if you treat the patient, this is telling you the probability of the event and the time. If you treat them, the probability of the event falls, and you run away from the time in which it would occur. And with that, I thank you for your attention.
Thank you very much. Maybe because of the time, a small question.
That's okay. That's fine. Thank you very much.
Thanks, Michael.
Thank you.
Again, we'll just move along to keep us on time. So the next speaker is Dr. Matthias Hilty from the University Hospital Zurich. He'll be speaking to us about analyzing microcirculatory alterations. Good day, sir.
Dear Chairman, dear Chairwomen, thank you so much for the kind introduction. So in the next 15 minutes, I am going to talk about the intersection of big data, as we have heard a lot about in the last talks, and physiology. And to be more precise, cardiovascular physiology. But before we start, and this is, of course, for many of you, a repetition, but I believe it is very important to be clear on the terms. Artificial intelligence it's a very good example of a term that really is very general. And before we start to dive into the different modalities, let's be clear what we are talking about. So in general, a system that perceives its environment and takes actions that maximizes the chances of achieving a goal. That's artificial intelligence. There is also the Church-Turing hypothesis, which many of you may know, which basically states that digital computers, they could simulate any process of formal reasoning. So artificial intelligence, I think we should differentiate into two subdivisions. And the first is the symbolic artificial intelligence. It basically encompasses deterministic algorithms that are used to apply a preset series of rules to the input data, and then trying to model, of course, the real world. It could model physiology as we know it, as we have built upon decades of scientific studies to understand the mechanisms. And those could be implemented in those sets of rules that are used in symbolic AI. And on the other hand, machine learning is a term, also quite broad term, that encompasses methodologies that apply comparatively simple rules to very large amounts of data and are optimized to recognize complex patterns. But be aware that these terms, there is a continuum between them. But in the example I'm going to show you, the analysis of the microcirculation using artificial intelligence, it goes into both of these worlds. This slide I won't go into in detail. It will just show a few of the methods that are commonly used in the world of machine learning. And as you see, as we progress downwards with the more complex models, maybe, like the deep learning neuronal networks, it's also increasingly difficult to actually see from the outside what a trained model is actually doing, what it is recognizing. So in the end, it increasingly will be a black box. And that puts it really onto the other side of this continuum between the symbolic AI and the machine learning methodologies. And another very important aspect for us in the ICU is that when we use the methods of artificial intelligence in the ICU, in our environment, we can use it in two different ways. We can use it to aggregate the big, large amount of data that we generate at the bedside every minute, every hour of treating our patients. And this, we have seen some very good examples of that in the previous talk. So it will reveal information that is actually there but was not recognizable before. On the other hand, it is still very important and our duty to develop new insights into better understanding and being able to measure actual physiology. So there, of course, is information with new measuring methods that are not accessible by aggregating the totality of the information that's already available. And of course, this second part and the first part, that they are independent of the methods that we are actually using. So artificial intelligence, symbolic AI, machine learning will be applied to both of those scenarios, but maybe a bit more on the side of the big data approach that we would use the machine learning methodologies. But in the example I'm showing you, we are going to cross this border. This is just a small introduction into the field of the sublingual dark field microscopy, which is a method to actually visualize the moving red blood cells in the capillaries. So it will give insight into the area where actually the oxygen goes into the tissue, into the cells where it is needed for survival, which is exactly a very important way to provide a new physiological insight instead of just using blood pressure, central venous pressure, or cardiac output as surrogate parameters for tissue oxygenation. And for some time, there are devices, the dark field microscopy, devices that are indirectly visualizing the tissue and thus visualizing the red blood cells moving through the capillaries, and they are easily applicable in the ICU setting, as you see. You know probably how these images look. We can identify individual single red blood cells moving through the tissue, and you can imagine that in this kind of image sequence, there is a lot of information contained, not only on the movement of the red blood cells, but also on the capillary density. So the main parameters that are based on physiology that we can extract from these images are the diffusion capacity of the microcirculation that consists of the capillary density, which is all of the places that these red blood cells could be over time, because they obviously don't leave the capillary bed, and the distance between the red blood cells, which we call capillary hematocrit. And keep in mind, I won't go into detail in this, but these functionalities of the microcirculation are independently regulated in the microcirculation, and they are not dependent directly on the parameters that we measure in the macro circulation, such as blood pressure or cardiac output. Taking one of those capillaries, we can align all of the pixels in these capillaries over time, over the image sequence that was recorded, and we can measure the here the derivative of this and get the red blood cell velocity. And that's the convection capacity. So this is very physiology-based and direct quantification of the capacity to carry oxygen to the tissue. We have developed in our group an algorithm that does this automatically in these image sequences, taking advantage of many openly available image analysis libraries and putting them together in a way to implement these physiological principles. They have been validated extensively and work very well and give a direct measurement of the physiology. So let's take one more step back to the years 2020 to 2022, when we all were busy treating patients with COVID-19. We took the opportunity to go in our ICU and measure the microcirculation in these patients, because it was a new disease. We did not know what was happening in the microcirculation in the tissue. And our initial hypothesis was maybe it's like sepsis, it's an inflammation with derangement of microcirculatory function, and that was our motivation to go and measure this. And we have performed a multi-center study in 4 university hospitals in Switzerland and the Netherlands, and have included 59 patients measured the microcirculation in the COVID units. And now the algorithm that I've showed you has analyzed 4 times 10 to the power of 12 red blood cell positions in these image sequences. So this is a way to apply those physiology-based rules to do things that would not otherwise be possible. Because by analyzing all of these red blood cell positions, we were able to quantify these 3 parameters of microcirculatory oxygen delivery to the tissue that I've introduced to you before. The use of these direct physiological principles, it ensures that we are able to interpret the results within a physiological context and also put it into context of previous research. And the findings, I will just briefly show you the findings in those physiological parameters. They were quite surprising to us, because in all of the parameters that we have discussed, we have seen an increased functionality of the systemic microcirculation in critically ill COVID-19 patients as compared to healthy volunteers. The microcirculation was doing more work and was delivering more oxygen extraction capacity to the tissue than in the volunteers. And at first, we thought there was something wrong with the algorithm. But we have performed a study a few years before where we took healthy volunteers to high altitude. There is going to be more information on this on Friday in the talk at 3 o'clock. It looked exactly the same. So our theory now is that the actual hypoxemia caused by lung injury would enable a functioning microcirculation to adapt to tissue hypoxia and increase its functionality to counteract. So that was the finding coming from these measurements using our physiology-based approach. But we also found some other features by looking at those image sequences. First, we found capillary leukocytes that were activated, moving through the capillaries. This is also not so surprising in a state of inflammation. It has been described before. But what we also found was red blood cell microaggregates, something that has not been described in this kind of patients. You can see an example here, and many instances of this was seen in those image sequences. Of course, we cannot say anything about the mechanisms from these findings, but we see something morphological is different in these patients than in the healthy volunteers. So we asked ourselves, could we differentiate those COVID patients from the healthy volunteers by, instead of looking at the physiological function, by looking at these morphological features? And of course, a deep learning neuronal network is optimized to find differences in morphological features in such image sequences. So we aimed to test if a supervised training of a two-dimensional convolutional neuronal network would be able to differentiate these COVID-19 patients from the healthy volunteers just by the sublingual HVM image sequences. And also we wanted to compare which method, the physiology-based algorithmic approach or the deep learning approach, would be best suited to make this differentiation. Neuronal networks, this is also something I don't go into detail here. It consists of a number of layers. The input layer and the output layers are probably the most important ones. The input layer is adapted to the data that I want to feed the network. The output layer is structured so that I get the results that I want. In our case, COVID or healthy, very simple. And then the hidden layers, they do the processing. And there is different mathematical principles behind this. I won't go into the details. Just the general properties of such a model are they are very computationally intensive in the training phase, which is where data with known endpoints are fed through the network, and the activation parameters of each of the nodes are adapted during this training phase. But then once there is a fully trained model, it's actually computationally cheap to apply them to new images. So it's a very elegant method. It's difficult to standardize the optimization of such a network. So there are different types, of course, of layers that could be put in different orders, but it's difficult to decide which network would be best suited for a given task. So this is one difficulty, and the other I already mentioned, it's difficult to see what it actually does in the end. So our study was built in the following way. We had the data set consisting of the COVID patients and the healthy volunteers. And usually these data sets are split into a training data set and a validation data set. The training data set is again split into a data set that's actually used for the training and a smaller portion that's used for in-training validation to ensure that the training is going in the right way. Out of this input data, we create a matrix that goes into the input layer. And there is one special feature that we added in this process here, and that is that we used our algorithm, the physiology-based algorithm, and we took some of the interim pre-processed data that went into this input matrix. So it was a pre-processing of the raw data that was used for the training and analysis of the neuronal network. Then, of course, in many, many iterations, this neuronal network is trained, and we end up with a feature set that we are able to use on new images, which we are doing, of course, in the internal validation data set. And there, we use the same pre-processing to put our data into the input layer and then get the result of the prediction, COVID versus healthy. And one thing we did also was to use an external validation data set collected in a different center that would provide information if this is really generalizable, if our model really works in a general scenario. So in the end, the input matrix resulting from the training data set contained 50 times 10 to the power of 6 points that went into the network to train. The network consisted of 13 million trainable nodes and was trained over about 300 epochs, and you see here in the training data that there is no overtraining, and the training worked well, basically. So what did we find? We found that in internal validation, in fact, the deep learning-based model reached an AUC of 80%, and it exceeded slightly the algorithm-based differentiation. But then when we combined both models, we combined in a logistic regression model the results of the algorithm-based and the deep learning model, and then we reached an even better result, which I think is a very interesting finding. And also in the external validation, you see it in the AUC to the right side, both models proved to be robust, and that's of course a very important finding. So successful training of a deep learning neural network was possible for the detection of microcirculatory alterations measured in the sublingual microcirculation. This was in part enabled by pre-processing of the data using an algorithm that is based on physiological principles. And in the end, the finding that the combination of both methods, the algorithm-based and the deep learning model-based approach, would lead to the best results, I think show that the physiology is an important addition to the findings we make with those black boxes that we call the neuronal networks. This proof of concept, of course, it should be applied in the future to more scenarios. This is just one scenario of many that we can use this methodology in. So there is this discussion we started in the beginning, using AI to analyze big data versus developing new insights into physiology with new measurements. I think the message here, we need to combine both approaches to reach the best results. And with this, I thank you for your attention.
Any questions? Matthias, I'd ask to have one. Did you learn anything in terms of the correlation of the microaggregates that you noted earlier in your findings at the end? Do they play a role?
That's a very good question. I mean, we have no way of knowing that because we don't know what was actually the thing that the neuronal network recognized. I know there are techniques that are quite newly developed to examine what a neuronal network is doing once it's trained, but we did not have access to these kinds of methodology. So we simply trained the network and tested what it would recognize. So we cannot make any new conclusions on the significance of these findings. And there we certainly will rely on our knowledge of physiology to further examine that.
It would be intriguing to think that maybe the aggregates suggest some impairment of the red blood cells themselves and ability to transport oxygen, and hence the response would be, like you said, would be similar to a higher elevation requirement by the microcirculation to adapt to a lower oxygen transport system. If those, anyway, just intriguing. Thank you very much.
Thank you.
So now we proceed to our next speaker, Soojin Park from New York, and we will move to the cerebral complications.
Hello. I'm going to change course here and stop talking about microcirculation and talk more about cerebral complications. I have no disclosures related to this talk. So in the neuro ICU, we are dealing with the most black box of patients. A lot of our patients have decreased mental status. Some of them are in an iatrogenic or in a disease resulting coma. And we're looking for secondary brain injury that is time dependent for intervention to make a difference. And so we really rely upon all of these types of monitors, both cardiac, respiratory, and especially neurological monitors, to look for signs of, too little blood, too much blood, too little pressure, too much pressure, seizures, metabolic crisis, and so forth. And so the challenge is, and the opportunity is an opportunity, which is we have a lot of different kinds of data that are different frequencies with different kinds of artifact, and we can acquire all this data and sync it together, and we can try to gain information from that data. I'm also very interested in the delivery of this information because we can do this all in a laboratory, but it's really not useful unless we can deliver it to clinicians to really supplement our ability to take care of multiple patients and in this time-dependent manner. So the examples I'm going to talk about in the 15 minutes I have is really number 1, 3, and 4, which is non-convulsive seizures, CSF or cerebral spinal fluid infection from our frequently used catheters, and then ischemia or stroke that happens after an aneurysmal rupture. I'll call that DCI or delayed cerebral ischemia. So first, non-convulsive seizures are pretty common, as you know. It's prevalent in all ICUs. And currently the way it's managed is with a bedside review in a continuous manner, spot checks. A nurse might look at it and say, this doesn't look right, or the patient is really fluctuating, take a peek. We might look at it and qualitatively say, this looks like a seizure. Or periodically, you might have an epileptologist, maybe at best twice a day, review it in like 12-hour segments and say, this is definitely a seizure, you were getting too excited, or you missed this one. And so why is that a problem? It's because non-convulsive seizures are very, very common, and they likely damage the brain. So the longer you seize, the longer you seize. So early attempts at this were limited because of the poor data sets that were available. They were highly specialized. They were usually in a very specific patient population, maybe derived from like an intracranial EEG in an operating room that was placed for the operation and then removed. And so you can automatically see, because of the small number of patients as well as the very specialized type of EEG and the circumstance they were obtained in, it's very hard to generalize anything you were to do, even if you have very special techniques. They really need to leverage many, many more patients than this. And so fortunately, people have started to recognize that working together is, rather than being competition, can be really beneficial for patient care and for human health. And so these are two really nice examples of that, when people came together and made it more like a gaming, a competition. You really compete for the best ability on very large shared data sets to try to establish automated approaches to analyzing those features so that every non-convulsive seizure eventually can be automatically detected with high sensitivity and high specificity. And now we're in the era where we have companies that are leveraging some of these algorithms to try to monitor the burden of seizures. And so still it's not completely sensitive and for all types and burden of number of seizures, and certainly not specific. And yet, if we continue to look at this as requiring perfection, perfection becomes the enemy of the good. So even with this very modern approved device, you still miss about 12% of seizures. And yet it doesn't mean that neurologists or epileptologists or neurointensivists or intensivists are going to be out of a job, right? So this is really to reduce the hours of time that would require to do a first pass. And for the majority of seizures that are happening, we have now the advantage of potentially being able to identify them before the non-convulsive seizure becomes status epilepticus. So in terms of interpretable AI and sort of scorable systems, this is also machine learning and AI, right? So you look at this model, it's an elastic net model, not mine, this is Cynthia Rudin's work. And so you look at how you can take the qualitative features of an EEG and say, well, what's the likelihood that this person is going to develop seizures? So this is not quite seizure-like activity, but it's very suspicious for. But not all patients who have these end up having seizures. And so looking at large data sets, you can really look at that label of eventual seizures and try to build a model. But if I were to try to, implement this elastic net with these kinds of weights on these variables, it'd be very difficult to do that. And so you can adjust that and make it into a scoreable thing. I mean, the CHADS2 score, the TIMI score, these are all similar types of scores. And so this is the 2 helps 2B score, which takes, again, qualitative things that doesn't take the epileptologist out of the loop with interpretation, but it really gives you a very good, specific, and sensitive prediction of which patient would benefit for more aggressive monitoring and potentially prophylactic medication. So moving on to the second example, I'm very interested in leveraging information from all of the signals, not just the neurological signals, but certainly the interaction and maybe even just the cardiopulmonary signals themselves. This is what it will look like if I just sort of label them and put them side by side and try to look at trends and put little heat maps there. But what can you do beyond that? So my second example is looking at the intracranial pressure waveform. And so we all know when we're being trained to look at these waveforms, and the left here is a very normal looking one. I don't know if this is a laser. Nope. So the one on the left, there it is. Oh, yeah. So this is a very normal-looking ICP waveform. As you will recognize, it's really based on the cardiac cycle, like all waveforms in the body, well, except for EEG. And so you look at this ICP waveform, you see P1, P2, P3. And this order of amplitude is quite normal, and it gives you information about the compliance or the sponginess of the brain. It also tells you about if there's space-occupying disease. You have to figure out the differential, but just tells you compliance is decreasing if your P2 becomes higher than your P1. And you can walk by a room and look at it and say, this person is having a problem. But very frequently, we're walking by the room, and that's not what we're paying attention to. We're listening to alarms. Sometimes we're ignoring those alarms. We're really not paying attention to every single waveform that could be informative. And so if you let this go, it becomes this very blunted, tombstone-looking appearing waveform, and yet the mean or the average ICP could be still normal. But eventually, if this were to continue, it becomes this asymptotic thing where the ICP then gets elevated, and then you're in a crisis. So how can we extract that knowledge and build it into a tool? So when you have something called hydrocephalus, you have water on the brain, the ventricle or the virtual space, which is filled with your cerebral spinal fluid, can get enlarged, and it pushes on the normal structures of the brain. And that impacts the sponginess and the compliance of that brain parenchyma. So what we do to treat this is we place something called an external ventricular drain, which I'll shorten to EVD. And that EVD, when it's open, you see this is clamped and open here. You see it's clamped to the patient, and then this transducer gives this. You have a kind of a physiologic waveform. Even amplified is really nonsensical because you have this continuous flow into this drainage bag. But then when you close it, you clamp it, now you can have a reverberating column of fluid in this manometer, which then can be amplified into a real waveform. And that waveform is an opportunity to look at what I just showed you of P1 to P2 to P3. Most of the patients who are treated with hydrocephalus in the acute setting have a ictus of blood usually, and then that gets treated with this drain, and then you have equilibrium, and most centers will keep it open to drainage. And so you have this nice homeostasis where you really should have a very stable looking P1, P2, P3, whether it looks like this or whether it looks like this. And so if you have that homeostatic equilibrium state where you no longer have the inducing pressure to change the compliance in the brain, when it's open, you clamp it for a couple of seconds or a couple of minutes every hour for nursing care, you have the opportunity to leverage these waveforms to say, is it changing? And if it's changing, it's not from hydrocephalus because it takes time for that to develop. That means there's something else affecting the compliance or the sponginess of the brain. And what else can do that but infection? And so what we observed anecdotally at the bedside was we were seeing patients with a lot of these kinds of waveforms and a lot of those tombstone-like waveforms. And we were noticing, we went around, we said, okay, what's different about this patient? And after many, many observations said, you know what? A lot of these patients have low pressure hydrocephalus and they end up having infection. So we said, okay, well, that makes sense, right? Infection of the ependymal cell lining of the ventricular space causes an inflammation which affects the local parenchyma and changes the poro and viscoelastic properties of that brain, which changes the compliance, the sponginess of the brain. So if that might be the mechanism by which this occurs, why can't we leverage the changed waveform morphology in that sort of homeostatic space to then identify you now have an infection? So based on that background, we developed that hypothesis and we looked at this. So we identified all culture-positive ventriculitis or infection. We looked at them in a time-dependent manner. We normalized them to the day that you sent the sample, which we sent on a regular basis, so it was non-biased sample of data in our center. We sent CSF on a very regular basis. And the day that the CSF was sent, and then came back positive somewhere between a day or half a day after that CSF was sent with a gram stain, or definitely a culture that told you that this was a ventriculitis, we were able to look at each of those days leading up to that day the CSF was sent. And what we did was we did a lot of steps on trying to see, like in terms of like gait analysis, you can do a stretching or a dynamic time warping of each of these waveforms to make sure you're comparing the quality and not something that's influenced by, like, say, the heart rate. Excuse me. And we were able to do this clustering. We had some metrics to make sure we had optimal clusters that were very self-similar, as well as, this represents the number of waveforms that contributed to each of these automatically data-driven clusters. We had one single step in there that was semi-supervised, where we created meta-clusters, 3 of them. One where we had sort of a bi- or triphasic looking waveform, one where it looked more like tombstoney or blunted, and one, even though we had an artifact cleaning stage as a first pass, retained the amount of artifactual waveforms. And then we looked at this histogram, so we look, or distribution. And this is a combination of all of these days before the ventriculitis CSF was sent. And you can see the distribution of very normal or bi- or triphasic waveforms, and then these blunted tombstones, and you have like a minimal amount of artifact. And then on the day of the CSF being sent, you see this big change, and it's statistically significant of this distribution, where you have very few normal or bi- or triphasic waveforms, many more blunted ones, and even more artifact. And despite treatment, this pattern persisted. And so we said, okay, well, this is really cool. This is really cool if we can say, look at the day before, you see that happening even the day before. So if we can identify that somebody has an infection a day or a day and a half before a clinician can actually do it, if you're lucky enough to send the CSF in a center that doesn't send it all the time like we do, then you've actually gained time, the ability to treat earlier with infection, and actually with more precision and without sampling CSF, which in and of itself introduces a risk of infection when you sample the CSF. And so what we did was we found some friends at shock trauma in Maryland. We got more patients. These are very high impact but low frequency events. So over an entire year, you might place about 100 or 200 EVDs at most. And if you have infection in 25% of them, but bacteria positive in 20% of that, that's quite a small number. And so if you want to look at fancy features like this, or even add ones to improve precision of your model that's externally validatable, you actually need many, many more patients. And so we've been fortunate to actually work with the shock trauma team to just double the number of patients, find matched controls, and build a machine learning model based on natural language processing. We borrowed a method called the bag of words, and we used this like there are 3 words in a bag, and we identified when that changes. And so that works. You're able to identify patients in real time that are having infection in a temporal fashion. And so we still can't really build a model that's really accurate with just 200 patients or 100 patients. And so we've actually just been funded to do a federated learning system with 4 centers, which we hope to acquire 2,000 patients over 5 years. And that will be good open access data set to look at all types of things to increase the optimization of management of hydrocephalus. So the third example is in subarachnoid hemorrhage or aneurysm rupture. And so we recognize that in these 2 experiments, where we did a very data-driven feature engineering experiment, meaning I didn't have an idea of what pattern in the blood pressure would interact with what pattern in the heart rate or respiratory rate that was going to be predictive of this outcome. And we had done a prior experiment, very simple Bayesian statistics, to look at, wow, there's actually signal in heart rate, respiratory rate, and blood pressure in a neurological disease to predict that. And so based on that being supported, we did this more fancy random number generator. We just sort of iteratively matched random number generated lengths of data on all of these different vital signs, and then we send it to the machine and say, can you find a pattern between all these random lengths, random numbers, and to see if you fit it. And this is a technique that has worked and is actually maximized for like making machine learning operations very parsimonious. You can achieve this with random numbers in very few iterations. And so we just innovated in terms of making it temporal, time varying over time, but varying over time. And we were able to say, this actually works. But that's a very fancy method to get you a non-interpretable signal to then predict a good outcome. And we were able to do that in this other way, which is dictionary learning, which is sort of the picture negative of that, where we're now solving for what's the optimal waveform, and yet still very data-driven. When you look at, and these are the number of iterations it takes, not very many, to solve for that equation, and you find these optimal variations in the lengths of time you need for blood pressure, et cetera, but it's still very non-interpretable. So he said, do we need to be this fancy, to detect this? And why do we think this is happening? Well, we think that there is a signal that is relying upon the inflammatory reflex, that there might be some inflammatory process that's affecting the autonomic nervous system, influencing the vital signs and how they interact with one another. That's got to be what this is. And we know that inflammation plays a large role in the process of delayed cerebral ischemia. And so what we did is we borrowed from Randall Moorman's group's work, who looked at neonates and detected necrotizing enterocolitis and sepsis before clinically apparent by just looking at cross-correlations of vital signs. And we said, does this even work? Could we even see this signal with just mean values of the vital signs here and cross-correlations? And indeed, if you normalize or you anchor them to the time of onset of the outcome in nearly all of just the mean values, in nearly all of the cross-correlations, which is a simple way of featurizing that relationship, this very complicated thing we found, you can really see a signal as statistically significant. And this is a multi-level linear regression, which looks at statistical difference between groups over time of data. And so, but if you were trying to look for a single patient, you really couldn't see, look at that whole overlap. I can't say that a mean respiratory rate of 12 or whatever that is going to be predictive of that patient having this outcome, right? And so we were saying, how can we look at these patterns? And now this is interpretable because I know what variables went in and which feature I made, which is this cross-correlation, and can we detect a model that does that? And so we were able to build a model that worked on our data set, and we found two groups of friends, one in Houston and one in Germany, and it seemed to work. And so there is a very clear threshold that occurs in our data as well as the one in Houston. And this one was different, but it was defined because our practice is a little bit different. And so we've really explored that further. And now this is implemented in our hospital in a demonstration environment. We're now doing a silent clinical validation for safety, for precision recall, and especially what we've learned, now we've enrolled 50 patients in this, is actually detecting DCI may not be where the value of this is, but in detecting who doesn't get DCI, it may. Because if we know who's not going to get it, and that's safer to say because they're still in the hospital, we can reduce the amount of resources related to that person's care. We can decide to take things out of their head, which leads to kind of chaining them to the bed, DVTs, decreased mobility at discharge, and the like. So I'm way over, so I'm just going to skip this last one. Basically, our approach is to take the biological basis of disease, extract knowledge-based features from those waveforms and all the different vital signs, and we build models for detection. And this is our groups. Now we have a very good score for another grant that's going to support this pipeline, especially this last part where we do user-centered design of these decision supports and how we implement that as a open source tool. Thanks.
So thank you for this wonderful presentation. I'm afraid for the sake of time, we will need to proceed.
Our next speaker will be speaking about coma. Will be our dear friend Mauro Oddo from the Centre Hospitalier Universitaire in Lausanne.
Thank
Welcome,
you.
Mauro.
Thank you, Marek. Thank you, the moderators. So I will try to be a little bit quick because of time and conclude with how artificial intelligence in the ICU may predict coma recovery. These are my disclosures. Essentially, I'm part of the Swiss Personalized Health Network, which has started 4 years ago as an infrastructure building to enable nationwide use and exchange of health data for research. So this is very active within the 5 university hospitals in Switzerland on several areas, and also intensive care is part of it with different projects. So the main theme I would like to review with you today is how so-called precision or individualized or personalized medicine could bring in the future to better identify homogeneity of patients within a panel of syndromes. If you think about traumatic brain injury, RDS, sepsis, we deal with heterogeneity. And so the idea here is to try and identify homogeneous groups of patients based on a set of similar unifying characteristics, and try and make more effective and precise predictions and or interventions. So with this paradigm, how bioinformatics and clinical data science can help us, and these summarizes quite nicely, I think, the interplay between data science, so how to better understand the data or the metadata that we have available in the electronic health records, the artificial intelligence, and specifically the machine learning, which with several statistical tools can enable us, again, either to predict, which will be the focus of this short presentation, or to help with better phenotyping disease. And this, by the way, will be a topic that will be addressed in the afternoon in another session. So I think this scheme is very helpful in visualizing the main two ways that we have with the use of machine learning. On the left-hand side, help us in predicting, which is the scope of this presentation, with the use of supervised learning and the different types of algorithms that are available, and especially the support vector machine and the random forest. With these tools, you can train models that can be tested and help us in predicting, in this case, recovery of coma or neurological complications. On the right-hand side, the unsupervised learning is a way that help you in phenotyping, so identify subgroups of patients that could respond or not, or even be harmed by a treatment. So I will focus mainly on prediction, and therefore will discuss studies that have used supervised learning. So I think, and I hope that you are familiar with this study, which is a very important study conducted at Columbia, so where the previous speaker is working together with Jan Klassen. And I will spend a little bit of time. So basically, it's very important to understand how this works clinically. So the first is to use neurological examination, and so to start with motor commands, and then to analyze the response towards a stimulus, a simple stimulus of, asking the patient to open the eyes or to move your finger, and then to analyze the response on the EEG in patients that are clinically not visually responsive. So you have to use for these analysis a full montage EEG. It will not work if you use a simplified EEG analysis, so at least a 19 electrodes EEG. And then you will use EEG in a quantitative matter and analyze spectral analysis. So you go through spectra on the EEG. And then you superpose on that. So these are short epochs of EEG. And then you superimpose the machine learning algorithm. And then you have the way to predict recovery in patients who are prolonged in coma after brain injury and do not seem to respond. So The previous study describes the method and was initially published in the New England Journal of Medicine in 2019. And they were identifying these condition, which is cognitive motor dissociation, and they will then confirm this study. The same group, Jan Klassen, you see also Soojin Park in the co-authors, was recently published last year in Lancet Neurology. So you see that among almost 600 patients that were screened, they identified a first cohort and then a second cohort. They combined these cohorts and they tested the prediction of a recovery from coma, again with the same methodology. So using the coma recovery scale revised, which it's very important clinically if you want to predict coma recovery in this setting, using a full montage EEG and again the machine learning algorithm as previously published. And so you see here that by applying this methodology, they were able to identify a subset of patients with cognitive motor dissociation that will eventually recover after 6 to 12 months, and so emerge from coma and have, for the majority, a neurological function which is above the level of threshold of 4. So patients who can even undergo a good neurological outcome, and this can be identified early within the ICU. And obviously, this methodology, as it's very nicely shown, brings the question about the availability everywhere, because it assumes the fact that you need to have a full montage EEG, neurology, algorithm. So it may not be readily available right now, but it gives you a view of what artificial intelligence can provide us in the future to better understand and predict the recovery from coma. There was also quite recently another study. The numbers are based on these algorithms are not very large, but still quite significant, more than 200 patients. And in this study, the outcome which was predicted was morbidity and mortality, so not neurological recovery, using again the same supervised machine learning, and using 14 clinical variables that were available, I would say relatively simple, including demographics, laboratory, and CT imaging. And the result of this machine learning algorithm is quite impressive based on this data, because looking at the specificity in predicting a poor outcome, mortality or in hospital morbidity, you see that especially one algorithm using the random forest approach provided almost the perfect specificity, so no wrong, which is the ideal prediction. So this is another example of how machine learning can predict recovery. Going a little bit further and opening outside neurological outcome and mortality, this study, which actually included data from previous studies than the one recently published Center TBI. So I will show you the methodology, but they use this algorithm to predict the probability that the patients will have a spike of ICP within the next 30 minutes. So here we are instead of predicting the coma recovery in the long term, we are trying to predict in the short time which patients may undergo intracranial hypertension and may have spikes of elevated intracranial pressure. This diagram that you see here was published by the group from Leuven, Gert Mayfreud, where you see that you have data in terms of the ICP levels in millimeter per mercury and also the duration of ICP. So again, the level, so the spike of ICP is important, but also the duration. And you see nicely that the threshold of ICP varies in between 22 and 25, but again, the duration is very important. So they used two cohorts. So the first cohort of almost 300 patients was derived from a total of 6 studies, especially the brain IET study, which included the majority of patients amongst these 290. And so this was the development cohort where the algorithm was used. So there was an algorithm training in this development cohort, and then it was externally validated within an additional 264 patients who were part of the more recent Center TBI initiative. And so you see that these cohorts are not entirely comparable, but the first was used to train the algorithm, and then the algorithm was tested in this validation cohort. And the results are summarized here. And what you see, in essence, is again that if your aim, your target for prediction is the time of prediction for an elevated ICP in the 30 minutes before the event onset, you see that this algorithm was able to predict quite accurately when ICP was going to be elevated, and especially based on the diagram that I have shown you before, when these ICP could be could put the patient in danger for a pure neurological outcome. So again, I think these data also show the promise of artificial intelligence, both in predicting early events that can aggravate coma recovery, and also, as previously shown, the trajectories of these patients in terms of mortality and neurological outcome. Now, to go further on this, and especially in patients with coma, with brain injury, we need to have large harmonized big data repositories to really have the amount of information available. And I think we are still in need for additional data in terms especially of biomarkers if we want to look at better phenotyping, for example, patients with heterogeneous condition like traumatic brain injury. And so these initiatives, multi-center, if you harmonize the data that you collect, these can be then used both in terms of prediction, but also, and I think that this is a way to go as well, to try and better phenotyping. And there are two main initiatives right now undergoing, the Center TBI and the Track TBI. So you know that there are a few biomarkers that are promising, like the neurofilament light or GFAP. And so this could be also helpful to phenotyping, and then to, for example, identify patients, as it has been done in sepsis and ARDS, that may be better served by certain treatments and other which are not. So we're not there yet for the brain injury population. This is the final slide that summarizes the way that we could use artificial intelligence to better redefine critical illness both in terms of patient trajectories, coma recovery, and also to better phenotyping the disease. I think we are not really ready yet at the bedside, but we are going closer. Again, there are a number of studies undergoing and recently published that go into these directions. So I think that there is hope also for patients with comatose conditions. Thank you.
Any questions? Mauro, I think compared to systemic diseases, I would guess that with regard to neurological central pathologies, we probably still are need of building that library, like you mentioned, probably more so than is available in some of the other areas of our body in terms of biomarkers and electrical interpretation, so forth, as we...
Yeah, we were discussing yesterday the issue of biomarkers. There are now, I think, two potential biomarkers that are helpful if you think about recovery from comatose condition. I think neurofilament light, especially right now, the diffuse axonal injury after a trauma is actually much more frequent than it was before. This is a promising biomarker, and there are large now studies again from tract TBI and center TBI. And these are also together with GFAP, which is an astrocyte biomarkers, also promising. And those two biomarkers are actually very specific for brain injury. Now, I think these two are the most promising. But again, we are not there yet as ARDS, sepsis in phenotyping, more specifically these conditions.
Right. Well, thanks, Mauro, very much.
Thank you.
So we now go back to the first speaker of our session, who will also close our session, Vincent Liu.
Great, thank you. And I'm going to be sensitive to time here. I think we've heard just a wonderful spectrum of opportunities for AI. I started by describing some of the ways that it would augment our capabilities, in filling roles, but then we took a tour through, biomolecular data, through physiologic data, and then ultimately through the integrated data pipeline. So maybe to end, I wanted to give some thoughts about, how we think about developing future predictive models. I'm going to talk mostly about EHR data because I think in the U.S. that's where we've seen a lot of focus recently, and that's an area where I work most frequently. But I think it has a lot of themes for other aspects of prediction. So this is just an overview that I did with medical student Michael Patton, where we examined the rise here in the dotted and solid line of EHR deployment across the US. And then we examined all of the PubMed literature that looked at prediction models using EHR data and then looked at the distribution of the outcomes. And I think what is clear is that with unlocking this high degree of data comes just a massive volume of studies. And I think that as EHRs get spread into more international settings and becomes uniform across a lot of different domains, we're probably going to see this. But it creates a problem, which is many people working kind of in a similar space. And in fact, this is a breakdown over time here from 1985 all the way through 2020 of publications of severity scores for in-hospital mortality. And here's the area under the curve, and the shapes are different scores, the shapes are the number of patients, including the cohort. The colors are different scores. I think what you see, it's hard to see, but if you draw your eye to this, I don't know that there's much of a trend here. And so that's also a challenge, is that it's not clear that the more time we've spent here, the more complex we've made the models, that we've necessarily improved that performance. And even when we take machine learning, so obviously you see towards this right side that there's an increase in the number of studies there, but you also see that what it's led to is kind of a widening of the performance. And perhaps at the upper echelon, an improvement in the overall characteristics of our AU ROCs, but really kind of uncertain benefits. And biomarker studies in sepsis, another, it's been undertaken for a long time. It's all over the map. And the point is not to say that all these studies are the same, because we know how challenging sepsis criteria are in the definition of outcomes. But it's to show that really there's quite a lot of heterogeneity, even while there's many, many, many studies that are doing the same thing. And then again here, machine learning performance with respect to sepsis prediction. And even though we see some really top echelon performer models, at the same time, we see a lot that are not as good. And so we are seeing kind of an explosion of these models. And I think we hear from, in different talks and from journal editors, what are we to do with all of these publications which are being submitted? So I think these are important framing considerations as we think about how we either collaborate, how we use multimodal data, as our previous speaker spoke about, but also, how we think about targeting. And so for those of you who might be young data scientists and entering this field, to avoid perhaps working in an area where there's much prior art and many folks, and really, I think, to consider strategically that we're not just looking under the lamppost, but that we're really looking at a condition and its opportunities for prediction. I think there's kind of three phrases that come to mind, US phrases. An ounce of prevention is worth a pound of cure, and we heard that earlier today, right? In terms of, when we do prediction, we want to have the optimal opportunity really to intervene and make a difference down the road. And if we do that early, we will probably have the greatest opportunity to mitigate the downstream consequences. This phrase, all models are wrong, but some are useful, right? We're never going to have perfection, but it really depends on how we apply it, the afferent arm, as Michelle spoke about. And then I think ultimately for us as a field, the best way to predict the future is to invent it. And it's on us to choose the right targets, to build the collaborations, ultimately to share the data sets that are multimodal, for us to have the greatest opportunity to make a difference and impact for our patients. So I'll just give some examples. We know from studies epidemiologically that the substantial majority, perhaps the overwhelming majority of sepsis is present on admission. And we know that, there are certainly patients who acquire sepsis in the hospital. Is it 10%? Is it 15%? Those patients have a very bad outcome. But those are kind of fundamentally a different type of patient. And yet, I think we see a large amount of sepsis models that are focused in the ICU or even in the ED. But sometimes this is a picture of military assault rifle wound profiles. And what it's looking at is the trajectory of the exit wound as a bullet moves through the body. And I sometimes feel like that's what we're examining. We're examining an exit wound, right? And what we need to do for those who are focused strictly in the ICU, for example, is hopefully move up in time, right? More towards that entrance wound, and that might be care that's delivered in the ED. Ultimately towards the gunshot itself, right? And that would be identifying patients in the outpatient setting who have the high risk, and then blunting the effects of a severe infection such that they never end up in the hospital in the first place, and thus we won't be spending a lot of time patching up those wounds. I think in COVID we've seen that that's possible. Population-based acute infection management that includes diagnosis, risk stratification, ongoing monitoring, up triage when necessary. Novel therapeutics developed delivered both in the inpatient and the outpatient setting. So that's just an example to, I think, give you some food for thought. All models are wrong, some are useful, and in silico, retrospective performance measurement is easy, doing something is hard. And this is where we've already heard there's a major gap in the field. So we've talked a little bit about the EPIC sepsis predictive model and the feeling that it falls short, that it exhibited poor discrimination and calibration when externally assessed. And yet, in this study, they deployed it in a randomized quality improvement setting in which the validation actually was very acceptable. And the alert fired. Sometimes with sepsis, the concern is the alert fires too late. It did alert 54% of the time before antibiotics were given, so that's not 100%, but that's a little bit better than some other reports we've seen. And what they found was that it shortened the time to antibiotics, and it lengthened the time of days alive and out of hospital. So the question really is it possible, are the performance metrics of this model high or low? I think that's still an open question. But can we use an actually relatively poorly performing model to deliver a quite effective intervention? And I think the answer to that is likely to be yes if we put it into the right system. Right? Where there's a lot of non-standardization and heterogeneity in the way we practice, we have an opportunity to use even a relatively modestly performing score to align the work that we do and drive towards earlier recognition and treatment. And this gets really into this. The best way to predict the future is to invent it. And we have to consider kind of our Pareto curves in terms of how we strategically invest in development. So here on the y-axis is what is our outcomes benefit. We're at the top. We're at the maximal theoretical benefit we can in caring for our patient. And then on the bottom x-axis, we have kind of our level of effort. And you could imagine a curve in which we have a quality improvement intervention, something simple, something that doesn't involve a technological intervention, and maybe that's education about how to improve recognition of sepsis and earlier antibiotics. And depending on what the shape of this curve is, you could actually recoup most of the outcomes benefit you're going to see at a relatively low implementation. And then let's say we put in a second intervention. Let's say this is self-measurement of timeliness to antibiotics. You could then recoup a little bit more, but it's going to take a good amount of work. The key here is that what might be available for an AI tool is actually very small, above what is already available through just traditional, we might call them dumb approaches rather than smart approaches. But this is really important because the level of effort here might be substantial, yet the outcomes gain might be very small. Now let's use another example where the curve is a little bit different. You could imagine that, that for the same level of effort on this curve, your initial kind of quality improvement intervention yields very little benefit. The same for number 2. Now you have actually a substantial fraction in which the implementation of a tool now actually gets you a large benefit, right? And so we have to be strategic about thinking through these kind of issues and how we think about the potential downstream benefits of this. And then finally, in efforts where we actually don't know, we can't see into the future, and a lot of examples about cognitive dissonance and coma and CSF infection, et cetera, maybe really there's no kind of a traditional approach we can leverage, and really AI with modest amounts of effort is going to get us to gain most of the outcomes benefits. So I will stop there and just say an ounce of prevention is worth a pound of cure. All models are wrong, some are useful, and the best way to predict the future is to invent it. Thank you.